honorable dignitaries and delegates, I, Ramandeep Kaur Saini, Assistant Professor at Department of Community Physiotherapy at MGM School of Physiotherapy. I'll be the anchor for the conference proceedings for today and tomorrow. I warmly welcome all delegates and esteemed dignitaries for 2 days National Conference on Mainstreaming Rehabilitation in Healthcare System in India, organized by MGM Institute of Health Sciences, Navi, Mumbai, in collaboration with NITI Aayog, Government of India, and World Health Organization, India. Without further ado, we commence the inauguration of our national conference with lamp lighting ceremony. May I request Chief Guest Honorable Professor Dr. Shri Tanaji Rao Sawant, Honorable Minister of Public Health and Family Welfare, Government of Maharashtra, India, Honorable Shri Kamal Kishore Kadamji, Honorable Chancellor at MGM Institute of Health Science, Navi, Mumbai. I request Professor Dr. Sashank Dalvi, Honorable Vice Chancellor, MGM Institute of Health Science, to come on the dais, please. May I request Dr. Alexandra Roche, Technical Advisor of Rehabilitation Program at Department of Non-Communicable Disease, Rehabilitation and Disability, World Health Organization. I request Dr. Tashi Tobge, Regional Advisor of Disability, Injury Prevention and Rehabilitation at WHO, Southeast Asia Regional Office, Delhi. We welcome you, sir. May I request Dr. Mohammed Ashil, National Professional Officer, Injury Prevention and Disability at WHO, India. I request Padma Shri Dr. Raman Gangakhedkar, sir, former Head of Epidemiology and Communicable Diseases at Indian Council of Medical Research and Chairman of a Research Advisory Committee at MGM Institute of Health Sciences. Dr. Nitin Kadam, Honorable Pro Vice Chancellor at MGM Institute of Health Sciences. Dr. Yagna Shukla, Chairman, National Commission of Allied and Healthcare Professional, will be joining us virtually online. Dr. Muniraju, Deputy Advisor at NITI Aayog, Government of India. Dr. Ashu Grover, Head of Delivery Research at Indian Council of Medical Research. Dr. Gauri Nembiar Sen Gupta, Deputy Director General, Public Health and Director of Central Health Education Bureau. We may proceed with the lamp lighting ceremony. I request Dr. Rupali Roy, Assistant Director General, Directorate General Health Services, Ministry of Health and Family Welfare, Delhi. We welcome you, ma'am. We welcome Dr. Ravindra Singh from Indian Council of Medical Research.
नमस्ते शारदे देवी काश्मीरपुरवासिनी त्वामहं प्रार्थये नित्यं विद्यादानं च देहि मे या श्रद्धा धारणा मेधा वाग्देवी विधिवल्लभा भक्तजिह्वाग्रसदना शमादि गुणदायिनी नमामि यामिनीनाथ लेखालङ्कृतकुन्तलां भवानीं भवसन्ताप निर्वापणसुधानदीं भद्रकाल्यै नमो नित्यं सरस्वत्यै नमो नमः वेदवेदाङ्गवे स्थानेभ्य एव च ब्रह्मस्वरूपा परमा ज्योतिरूपा सनातने सर्वविद्यादिदेवीया सरस्वत्यै नमो नमः। यया विना जगत्सर्वं शाश्वतजीवन्मृतं भवेत् ज्ञानादिदेवीया तस्यै सरस्वत्यै नमो नमः। यया विना जगत्सर्वं मूकमुन्मत्तवत् सदा या देवी वागधिष्ठात्री तस्यै वाण्यै नमो नमः।
Thank you. Now I request Honorable Professor Dr. Sashank Talvi, Honorable Vice Chancellor at MGM Institute of Health Sciences, to deliver the welcome address. Welcome, sir.
Good morning to all. On the occasion of this conference organized at MGM Institute of Health Sciences, one of the top leading educational institute in the country, in collaboration with World Health Organization and NITI Aayog, Government of India, on one of the very important topic, mainstreaming rehabilitation in healthcare system in India. I welcome all for this particular conference. Due to certain other works, Honorable Professor Dr. Sri Tanaji Rao Sawant, Health Minister, Government of Maharashtra, expressed his inability to join the function, but he has expressed all the best wishes on the occasion of this particular conference. Sri Kamal Kishorji Kadam, Honorable Chancellor of this Premium Institute, Dr. Alexandra Roche, Technical Advisor, Rehabilitation Program, WHO Geneva, Switzerland, Dr. Tashi Tokfei, Southeast Asia region, the head, Dr. Mohammad Ashil, Indian head for this rehabilitation program as well as injury prevention. From NITI Aayog, Dr. Muniraju is joining online. Dr. Gauri Nambiar Senagupta, Director, CHEB. Dr. Ashuror is joining online. Dr. Ravindra Singh, Dr. Yagna Shukla, Chairman for National Commission. Dr. Raman Ganga Khedkar, a well-known scientist of the country, the moral support of the country, particularly everyone has experienced during the COVID time. Dr. Nitin Kadam, sir, all the dignitaries who have joined for this particular conference, all the faculty members, all the health professionals from the various relevant field, physiotherapist, prosthetics and orthotics, occupational therapist, assistive technologist of the country, speech and hearing aid, principals and deans of all the units of MGMIHS, and all the faculty members. The main, I welcome you all relevant people have called for this particular conference, and as the theme itself, mainstreaming rehabilitation services and the need for a large number of population of the country, more than 3% of the population of the country, which is in need of these services. WHO has already identified the various conditions, priority conditions for this, and on that the deliberations will happen for 2 days, how these all various activities for the disabilities in the various occasions can reinforce rehabilitation services in the country. WHO package for intervention of the rehabilitation, how that can be made available in all the sectors, and not only providing the services, how more important with that also the quality of the service that is being rendered. So the discussion, the deliberations, the 2 days will surely help in this particular conference. On the occasion of this conference, you have come to this premises of the MGM IHS Institute. Our unit, School of Physiotherapy, Prosthetics, Orthotics, have made a lot of efforts for organizing this particular conference. So I welcome you all on the occasion of this particular conference once again. Thank you very much.
Thank you so much, sir. Now we proceed with the felicitation ceremony. I request Professor Dr. Sashank Dalvi, Honorable Vice Chancellor, to felicitate Honorable Shri Kamal Kishore Kadamji, Honorable Chancellor at MGM Institute of Health Science. I request Honorable Dr. Nitin Kadam, Professor, Vice Chancellor, Pro Vice Chancellor at MGM Institute of Health Sciences, to felicitate Dr. Alexandra Roche, Technical Advisor of Rehabilitation Program at World Health Organization. May I request Honorable Pro Vice Chancellor, sir, to felicitate Dr. Tashi Tobge, Regional Advisor for Disability, Injury Prevention and Rehabilitation at World Health Organization. May I request Dr. Rajni Mullarapatan, convener of the conference and Professor Director at MGM School of Physiotherapy, to felicitate Dr. Mohammad Ashil, National Professor Officer, Injury Prevention and Disability at World Health Organization, India. May I request Pro Vice Chancellor, Sir, Dr. Nitin Kadam, to felicitate Padma Shri Dr. Raman Ganga Khedekar former head of epidemiology and communicable disease at Indian Council of Medical Research and chairman of Research Advisory Committee at MGM Institute of Health Sciences. I request Dr. Bela Agarwal, co-convener and professor and head of department at Cardiovascular and Respiratory Physiotherapy at MGM School of Physiotherapy, to felicitate Dr. Rupali Roy, Assistant Director General, Directorate General Health Services, Ministry of Health and Family Welfare, Delhi. I request Dr. Rajni Mularapatan, convener of the conference, to felicitate Professor Dr. Sashank Dalvi, Sir, Honorable Vice Chancellor. I request Dr. Bela Agarwal to felicitate Dr. Nitin Kadam, Pro Vice Chancellor at MGM Institute of Health Science. I request Dr. Triveni Shetty, Professor at MGM School of Physiotherapy, to felicitate Dr. Gauri Nembar Sengupta, Director at Central Health Education Bureau, Public Health. I request Dr. Bela Agarwal to felicitate Dr. Nitin Kadam, Pro Vice Chancellor, MGM Institute of Health Sciences. Now I invite Dr. Rajni Mularapatan, convener of the conference and professor director at MGM School of Physiotherapy, to present objective of the conference.
Namaskar. A very good morning to each and every one who's here on the dais and off the dais. Despite heavy rain, people have traveled across the country to be able to be here at MGM Institute of Health Sciences, which has taken this initiative along with great support from WHO office, the India office, the Southeast Asia office, as well as the headquarters, NITI Aayog, Government of India, the Ministry of Health and Family Welfare, the Center of Health Education Bureau, Indian Council of Medical Research, all the various organizations of the rehabilitation health workers, including the Society of Indian Physiotherapists, the National Institute of Occupational Therapy, the Indian Speech, Language and Hearing Institute, the various rehabilitation institutes across the country, including National Institute of Rehab, NIRTAR, All India Institute of Speech and Hearing, Indian Academy of Cerebral Palsy, Maharashtra Occupational Therapy and Physiotherapy Council, the Orthotics and Prosthetics Association of India. All of us here have come together from public as well as private domain including academic institutions like Bharati Vidyapeeth Deemed University, Ramaiah College of Physiotherapy in Bangalore, Manipal College of Allied Health Professionals, Kidyapur College in Kolkata, Sri Balaji Action Medical Institute in Delhi, Tata Institute of Fundamental Research, Mumbai, the General Practitioners Association of Greater Bombay, the Spinal Cord Society of India, the Indian Association of Assistive Technologies, World Spine Care Europe team will join us online, Mobility India. In addition to this, the non-government organizations like the Indian Red Cross Society, Able Disable All People Together, Lions Club, along with industry partners like Motorica, finance partners like the State Bank of India and the IDBI Bank, all of us here are together for this very cause of mainstreaming rehabilitation in the healthcare system of India. The objectives of this conference are to describe the need for reinforcing rehabilitation services in India, because the mantra of our government is that if we can measure it, we'll be able to address it. So that's the first objective of the conference. The second one is to deliberate on the package of interventions for rehabilitation for the 15 health conditions for appropriateness in Indian setting, including musculoskeletal conditions, neurological conditions, as well as cardiopulmonary conditions and malignant neoplasms. The third objective is to recommend future strategies for quality rehabilitation services in the country. We have done phenomenal efforts of the healthcare system in order to increase our average life expectancy. Today's life expectancy in India is 67.3 years, as we talk about. Our success in saving lives now has added years to life, and this has resulted in a growth of the aging population. Now in the 21st century, this is the time to come together to deliberate on how we can enhance the life of these saved lives and the years that we've added to the lives of the people. Rehabilitation is an essential health service which WHO is working very hard in order to promote, that it is necessary for anyone with acute or chronic health condition, an impairment or injury that limits functioning, and it's an essential health strategy, not a luxury or not something which can be affordable only for the few, which people in need should have access to without facing any financial hardships. In India, the alarming rise of prevalence of NCDs, the high prevalence of trauma and communicable diseases is already adding to the existing need for congenital and developmental conditions rehabilitation requirement. The morbidity which is caused by the disability, the social isolation which is caused by impaired functioning, the poor health-related quality of life caused by reduced functioning, and the reduced income of people all poses an urgent need to mainstream rehabilitation system. So today, the mantra is to come together, and in this highest populous country, this rehabilitation strategy which gets planned, which gets executed, is then likely to influence the rehabilitation scene of the entire world, because India is leading now in not only the number, but also the diversity and the complexity in the need of the people with rehabilitation services. So we are very, very pleased here at MGM Institute of Health Sciences, once again, to welcome each one of you who has come together. We very often say that this country is densely populated and the distance between people may not be much, but sometimes the distance between disciplines can be very wide. So I'm very, very glad and pleased to see that all the different health disciplines, medicine, surgery, rehabilitation workforce, finance, media, as well as industry has come together to voice for this need together and arrive at a concerted action plan for a roadmap which will make India lead in the rehabilitation strategic planning in the country, and also, as we said, will influence the rehabilitation scene of the world. So with this, we welcome each one of you once again, and we would like to now continue with the invited talks. So may we first invite before we begin with the invited talk, let me felicitate the ICMR Head for Disability Research, Dr. Ravinder Singh. So may I please request to felicitate Dr. Ravinder Singh.
I request Dr. Gauri Naembar Sen Gupta ma'am, Director of Central Health Education Bureau, to talk few words on how education on rehab can be beneficial.
Namaskar to one and all, respected dignitaries on the dais, colleagues from various fields across the country in the field of rehabilitation and other allied health sciences. Let me first congratulate MGM Institute of Health Sciences for organizing this scientific forum, which is a very, very important and an opportune forum for discussing not only rehabilitation, but functional limitation, something which we all forget. The word rehabilitation connotes that it is some specific person with some form of inability or disability, whereas functional limitation is a broader aspect. So I'm sure all of us will be slightly graduating from rehabilitation to functional limitation. And I must congratulate Dr. Rajani for giving me the opportunity to be a part of this particular forum. It is only her prayers that I was able to come today. Otherwise, it was pretty difficult for us to be here. Secondly, as a public health specialist for the last 25 years working in the field of health services, any kind of health system delivering any health service is incomplete without rehabilitation. So rehabilitation is already there. There may be issues with implementation, there may be issues with monitoring, there may be issues with addressing or generating evidence. But I assure you, rehabilitation is already a part of the health system. So when we talk of mainstreaming rehabilitation into health systems, we should be addressing ideas, innovations, or actually delivering evidences. And thirdly, in my current position as the Director of Central Health Education Bureau, we are committed to not only enhancing the awareness and the capacity building and behavioral research related to functional limitation, evidenced by the fact that we now work for health promotion for persons with disability, and along with ICMR, I have my very esteemed colleague, Dr. Ravinder Singh here, we have forayed into the aspect of training and awareness generation for assistive technologies, and we are currently in the process of regionalizing the 21 assistive products released by the ICMR as the national list of essential assistive products. We are in the process of developing 21 modules for the trainings of all the healthcare professionals and awareness generation materials for general public, including caregivers of persons with disability. So I assure you, in my current position as the Director CHEB, I will afford any kind of help and support that I can give from the Government of India side, And I also assure you that we will work towards functional limitations, awareness, training, and all aspects of delivering rehabilitation care services across the country. I once again congratulate the MGM Institute of Health Sciences, the Chancellor, the Vice Chancellor, and all the respected, learned, eminent speakers and other people who are going to be there for the next 2 days and deliberating on the topic of mainstreaming rehabilitation into healthcare services and primary healthcare. So thank you very much and congratulations once again.
Dear delegates, it's my pleasure to introduce our keynote speaker for today, Dr. Alexandra Roche, consultant for the WHO Rehabilitation Program since 2018 in Rehabilitation and Disability Unit of Department of Non-Communicable Disease at World Health Organization. She is a renowned expert in WHO's Rehabilitation 2030 initiative, where she has made significant contributions in development and promotion of WHO's package of intervention for rehabilitation in planning, budgeting, and implementing effective rehab services. Please join me in welcoming Dr. Alexandra Roche on stage to deliver on an overview on WHO Rehab 2030 initiative.
Very warm welcome. I just learned I will start with my welcome to all of you, and later we will have the keynote address. Okay, I start again. Dear delegates from the government, dear delegates from the MGM Institute of Health Sciences, dear delegates from the professional organizations, dear users of rehabilitation, beneficiaries of rehabilitation, and dear colleagues, dear rehabilitation colleagues, I'm extremely honored to be here, and I'm speaking on behalf also of my colleagues from the regional office and the country office. And I would like to start with a very short quote from Dr. Tedros Ghebreyesus, who is the Director General of the WHO. And the quote is very short. It says, "Rehabilitation is a human right." And he gave this quote last year when he launched the World Rehabilitation Alliance of rehabilitation stakeholders who work together to advocate, to raise awareness about rehabilitation, the needs, and the benefits. So, in the next days, during this conference, you and we will discuss many areas that are relevant to make sure that people have access to rehabilitation. And this is truly appreciated. So WHO is working since longer, but very intensively since 2017, to support countries in strengthening their health systems to integrate rehabilitation into their health systems. But this initiative that came from the rehabilitation community is so important, and I really want to congratulate you, and specifically Rajani, who initiated this. Why? Because the rehabilitation community is a voice for rehabilitation. The people working in rehabilitation, they are aware, they see the needs every day, but not only they see the needs, they also have the solutions to address the needs of people who are in need for rehabilitation, to help them to improve their functioning and well-being. So this is really, truly appreciated. And what I learned just this morning, I think this is the first time that all the different professional organizations and other stakeholders and governments come together to discuss how to strengthen rehabilitation, and specifically tomorrow, how to make sure that people who receive rehabilitation have access to evidence-based interventions. So we truly support this initiative, but, and this is also a call for action to you all, this should just be a starting point. So we expect that the initiative in India will continue, And you can trust WHO. We support you, the government, the institutes, the rehabilitation community in all your efforts to strengthen that people in India have access to rehabilitation. So we are looking very, very much forward to get to know you better during the next day. So please enjoy this meeting. Thank you so much.
I request Dr. Ravindra Singh from Indian Council of Medical Science and Research to talk few words.
Thank you for inviting me to this August meeting. I thank the management of MGM institutions, Honorable Chancellor, Vice Chancellor, and the organizing committee of this meeting. We know rehabilitation is an important area under health. But unfortunately, till now, the ownership is very less. We have been talking of health for all, we have been talking of Millennium Development Goals, we have been talking of Sustainable Development Goals, now we are talking of Viksit Bharat. We have initiated a series of roundtables on creating health as a part of Viksit Bharat, because until unless the population is healthy, we cannot achieve any goal, whatever is assigned, whether it is Viksit Bharat, whether it is Sustainable Development Goals. So rehabilitation plays a very important role in achieving those goals. I'm very happy that today we have come gather here to discuss that important area. I have the chance to review national health programs where rehabilitation could be one of the important component in those national health programs. But unfortunately, I have been talking to Ministry of Health people that we are lacking this area and we should take the corrective steps to fill that gap. All the national health programs, they talk of prevention and care or management of those conditions, but they stop at rehabilitation, which goes to somewhere else. So let us find out a way how to integrate it with health and provide more benefit to our populations. Thank you very much.
May I request Dr. Padma Shri, Dr. Raman Gangakhedkar, former Head of Epidemiology and Communicable Disease, ICMR, Chairman Research Advisory Committee at MGM Institute of Health Sciences, to share his view on mainstreaming rehabilitation.
Honorable Kamal Kishore Kadamji, Dr. Alexander Roche, all the dignitaries on the dais and friends. I'm not going to take longer. If you actually look at me, you might find I'm a patient representative, perhaps, who needs a rehabilitation by himself. Today, in last 10 years, health has been accorded high level of primacy in the interventions in the governmental interventions in India. But when we talk of health, most often it is only biological or medicinal interventions. We do not think in terms of offering health related to rehabilitation. One has to understand one thing, that when somebody is deceased and when he comes out, it's not only cure, but the residual damage which needs to be reduced as much as possible. Are we there? Perhaps not. If you actually look at the kinds of organizations that are attending, you suddenly realize that we need a coordinated effort. Because perhaps some of us may be meeting for the first time at this point in time. If Ayushman Bharat is going to provide us all the kind of services, it is time we need to speak about these rehabilitation services to be provided comprehensively. Now, is that a simple task? Perhaps not. And that's one of the reasons why this conference is focusing on the same. Perhaps the advocacy that we all will do will actually result into provision of these services. I wish all the delegates an intellectually stimulating time, because integration is one of the most difficult exercises, because each one of us always feels mine is a specialized field. So I have to first remove that thought and try to provide at least generic package. And I thank Dr. Rajni, MGM management, to have thought of having such a conference which will perhaps lead the advocacy that we need in India. Thank you.
Thank you so much, sir. Now I request Honorable Shri Kamal Kishore Kadam, sir, Chancellor, MGM Institute of Health Sciences, to deliver presidential address.
Dr. Dalvi, Vice Chancellor of Mahatma Gandhi Mission, University of Health Sciences, Dr. Muniraju SB, he is attending online, Deputy Advisor, NITI Aayog, Government of India. Dr. Ashu Grover, she is also attending this conference online, Head Implementation, Delivery Research, Indian Council of Medical Research. Dr. Yajna Shukla, Chairman, National Commission for Allied and Healthcare Professionals, Ministry of Health and Family Welfare. Padma Shri Dr. Raman Ganga Khedkar, former Head of Epidemiology and Communicable Diseases, ICMR. Dr. Alexandra Rao, Technical Advisor, Rehabilitation Program, Department of Non-Communicable Diseases, Health Organization, Geneva. And all dignitaries present on dais, honorable delegates. At the outset, I declare this conference inaugurated. Yesterday afternoon, Dr. Rajani Mulerapattam and Vice Chancellor came to my office and asked me to present on stage of today's conference. I was surprised, confused, baffled, because I'm not a man of medicine, surgical science, or physiotherapy science. I asked her. She said, you can address with your experience. And I said, yes, I have experience of undergoing physiotherapy. I have undergone physiotherapy of heart, physiotherapy stroke, physiotherapy accidents, and many other times. Few months back, I was unable to walk few yards, but I think now I can walk a few kilometers, and if dared, even can run also. So I asked her, Madam, you are doing so hard work in the department. I will come and attend the conference. Rajani Molerapattam, very active faculty. She wants to keep everything moving, no static or stable. All the time she is moving here and there. With a lot of efforts, she has organized this conference. All praise for her. Madam, what is physiotherapy? To keep the static things in motion. What engineers also do, their business is also to keep everything in motion. If it is in motion, the engine is right. If it is stable, then something is wrong, you have to keep it in motion. Same thing is in physiotherapy. One laboratory, what laboratory you have established there? She took me there and made me to walk.
Human movement science.
So, technological term I do not know. But she said with cameras fitted all around the track, she can point out or identify the diseases or defects in human gait and can correct it. It's wonderful. Madam, you and your associates have given a status to this department. Even chairman of Atomic Energy Commission, he has visited this place because of her. And he acknowledged, she was interested in her research. Therefore, I have come here and I have walked all around her department. Madam, I will request you to keep everything moving in the department and make the department healthy. अभी देखो ना, हमारा पैर टूट गया था, तो हम सोचे हम जिंदगी भर अब ऐसा ही रहेंगे. In my lifetime, I will be a lame person. But with physiotherapy, I could make it. I could walk. And that too, I think I can walk better, I think. So, in medical science also, At micro level, mega level, everything is moving. What is cardiogram? It represents graph, the movements of your heart. If it is moving, it is okay, all right. And if it becomes straight, stable, what happens, Narsati? So everything is over. Similarly, every organ of human body, even we think brain is stable, but no. There are micro movements in brain also. Every organ of human body is moving. And life is long till everything is in movement. I request the officers of the NITI Aayog and Government of India, those who are present here, to give importance to this branch of medicine. This is the necessary. Rehabilitation of human organs is the most important thing, and for that, special emphasis to be given by Government of India. I hope you will consider my point and convince the concerned authorities. Number of foreign delegates are here. Their contribution to the field is important. I welcome them that you have come a long way considering the importance of this conference. And all the delegates, all Morera Pattam Madam said me, all heads of this organization from all India, they are attending this conference. I am thankful to them. Keep it on, and Morera Pattam Madam, I cannot pronounce you correctly. It's a bit difficult. First name is all right. That is common. I thank you for organizing this conference, and I thank all the honorable delegates for attending this conference. Thank you very much.
Thank you so much, sir, for addressing us. Now, may I request Dr. Nitin Kadam, Honorable Pro Vice Chancellor of MGM Institute of Health Sciences, to deliver vote of thanks for the inaugural ceremony.
I want to be very brief, but unfortunately I can't, because so many brains, many hearts, and many hands were working day and night for this event under leadership of Dr. Rajani Mullar-Patnam, who has organized this conference. So it's a great pleasure of Mahatma Gandhi Mission Institute of Health Sciences to host this very important event, Mainstreaming Rehabilitation in Healthcare Systems in India. This is organized in collaboration with NITI Aayog, Government of India, and World Health Organization India. We wish to thank Professor Dr. Shri Tanaji Rao Sawant, Honorable Minister of Public Health and Family Welfare, Government of Maharashtra, who, because of some emergency meeting, I think he could not attend here, but he has sent his message. The MGM Institute of Health Sciences, MGM School of Physiotherapy, and MGM Institute's University Department of Prosthetic and Orthotics, in collaboration with NITI Aayog, Government of India, and World Health Organization. We also thank the guests of honor, Mr. Muniraj, Deputy Advisor, NITI Aayog, Government of India, Dr. Ashu Grover, Head Implementation Delivery Research, Indian Council of Medical Research, Dr. Gauri Nambiar, DDG, Director, Central Health Education Bureau, Dr. Yagna Shukla, Chairman, National Commission of Allied and Healthcare Professionals, Ministry of Health and Family Welfare, Dr. Rupali Roy, Assistant Director General, Director General Health Services, Ministry of Health and Family Welfare, Delhi, Dr. Prashant Javade, the Chief Medical Officer of Health, Navi Mumbai Municipal Corporation. He helped us a lot for their time and valuable contribution through these 2 days of intense discussion on how to integrate rehabilitation into the system despite several challenges that are currently faced. We are extremely grateful for the support extended by the World Health Organization for collaborating with MGM Institute of Health Sciences. The vision of MGM Institute of Health Sciences is guided by the Gandhian philosophy. To wipe every tear from every eye is in line with that of World Health Organization to provide health for all. WHO has made a tremendous efforts of putting together the package of interventions for rehabilitation for the various health conditions, and we look forward to implementing them and culturally adopting them to meet the national needs of our people. So we thank Dr. Alexandra Rauch, WHO Rehabilitation Program, WHO Headquarters Office, Geneva. We thank Dr. Tashi, WHO Southeast Asia Office, Dr. Mohammed Asil, National Professional Officer, Injury Prevention Disabilities, WHO India, for their guidance in planning of the conference. And we hope that we'll be able to undertake many more collaborative projects with WHO in the future. We are extremely thankful to the patrons and advisors who have guided the program and extended their wholehearted support to the organization of this event at MGM IHS. Honorable Shri Kamal Kishorji Kadam, Chancellor, MGM Institute of Health Sciences, Navi Mumbai, Shri A.N. Kadam, Secretary of the MGM Trust, Dr. P.M. Jadhav, Vice Chairman, MGM Trust, Dr. Sudhir Kadam, Executive Council Member and the former Vice Chancellor of the MGM Institute of Health Sciences, Professor Dr. Shashank Dalvi, Vice Chairman, MGM Institute of Health Sciences, Navi Mumbai, Padma Shri Dr. Raman Ganga Khedkar, former Head Epidemiology and Communicable Diseases, ICMR, and Chairman, Research Advisory Committee of MGM IHS. Our colleagues, Dr. Chandramani Pathak, Rajesh Goyal, Dr. Narshetty, Dr. Sulba Karte Madam, Dr. Vijay, Medical Director, MGM Hospital, Vashi, and Lieutenant General Dr. K.R. Salgotra, Hospital Director, MGM Medical College and Hospital, Kamothe, Navi Mumbai. These dignitaries have led the pathway for all the healthcare professionals and provided their support for this much-needed cause of advocating and weaving of rehabilitation into the mainstream healthcare. We would like to thank the various organizations who have extended support and participated in the conference. Dr. Pierre Cote, Chair, Disability Rehabilitation, Ontario Technology University, Canada. Dr. Adam, President, World Spine Care, Europe, United Kingdom. Dr. Nitish Bansal, Honorary Secretary, Society of Indian Physiotherapists. Mr. Prakash Mehta, President, Indian Association of Assistive Technologies. Dr. Harvinder Chabra, Director, Department of Spine and Rehabilitation Center and President of the Spinal Cord Society. Dr. Sanjay Wadhwa, All India Institute of Medical Sciences, New Delhi. Dr. Asha Chitnis, Vice President, Indian Academy of the Cerebral Palsy, International Society of Prosthetics and Orthotics. Dr. Professor Prakash Bhuminathan, the Indian Speech, Language and Hearing Association. Dr. P.K. Lenka, Head of Department of the Prosthetics and Orthotics, National Institute of Locomotor Disabilities. Dr. Charu Sharma, Rehabilitation Program Manager, International Committee of the Red Cross, Geneva. Dr. Ritu Ghosh, Mobility India. Mr. Pankaj Kumar Tiwari, thanks to him, the Insurance Regulatory and Development Authority, Government of India. Dr. Deepwan Ghosh, Associate Professor, Kinderpur College of University of Calcutta. Dr. Maria Jindani, President, the Society of Cardiovascular and Pulmonary Rehabilitation, the All India Occupational Therapists Association, and the Orthotics and Prosthetic Association of India. We wish to thank all the delegates for their participation and hope that through these 2 days, there will be ample of opportunities to explore collaborative partnership, strategic planning, and the sustainable integrated model with a shared vision for the rehabilitation to all persons with rehabilitation needs in India and their inclusion in the society. We hope the information gathered in this conference will lead to more knowledge and wisdom to create more inclusive society and the approaches towards disability that were based on the charity should be viewed as a human right. Thank you very much, and thank you very much, everybody.
Thank you so much, sir. Now may I request all the dignitaries to be seated off the dais. Request Dr. Rajni Mularpatan to introduce Dr. Alexandra Roche.
A very good morning to each one here, and we continue from the inaugural ceremony. If you'd like to stretch, and as we now begin and get ready for the keynote address of this conference, which is going to be delivered by Dr. Alexandra Roche. And I must say here, before I introduce formally, that her energy, her indomitable spirit to be able to take the rehabilitation program at the headquarters and to bring to the notice that now that the world has taken over the effort of combating with communicable diseases, it's time now to move on to the non-communicable diseases. And her contribution in the development of the package of intervention for rehabilitation, which some of us who are here in the audience have been a part of development, have seen that effort going for the last few years, and that has been the consistent effort. Last July 2023, after the rehabilitation conference, when we met virtually, is when we started talking about this conference. And in 11 months, this is what we have been able to achieve, to bring all the organizations, professions together on this platform for this. So it's my privilege to be able to introduce Dr. Alexandra Roche, who's a consultant for the World Health Organization Rehabilitation Program since 2018. So we see what it is at the end of 6 years. She led the development of package of interventions for rehabilitation and continues the projects related to the WHO Rehabilitation 2030 initiative. Believe me, this package of intervention rehabilitation, which was developed in her leadership, has been a colossal task to bring rehabilitation professionals across the globe. There would be at least several meetings, I would not even have a count of how many per week. And most importantly, as we heard even earlier, bringing in the wavelength, synchronizing, harmonizing all the rehabilitation professionals, and that too on a virtual program, in a virtual mode, and particularly when the world was facing the massive effect of COVID. So internally, each one was battling COVID in every country, but virtually she was doing this task, which has begun. So a special applause for that. Dr. Alexandra started her career as a physiotherapist in Germany in the inpatient and outpatient rehabilitation of people with musculoskeletal, neurological, and cardiopulmonary diseases. After 8 years of clinical practice, she continued her career as a physical therapy teacher. And during this time, she completed a bachelor's degree in applied health sciences. Thereafter, she continued her career as a researcher at the Swiss Paraplegic Research Foundation, and her research focused on the implementation of international classification of functioning disability and health, the ICF, in the rehabilitation practice and on the topic of physical activity in people with spinal cord injuries. So with this introduction, I think we have today amongst us a face whom can relate to the ICF or the International Classification of Functioning Model. So we will have these opportunities over the next 2 days to be able to interact with her in person. So it's a great privilege and honor to welcome Dr. Alexandra Roche to deliver the keynote address for this conference. And thank you ever so much for all this effort that you have made for the rehabilitation professionals and for this particular conference. So thank you once again, and we welcome you to deliver the keynote address for today. Thank you.
Rajani, where are you? She left the room. So I could respond to all her words, but I will do this tomorrow with respect to the package of interventions for rehabilitation. Only one word. And I think this is something that is not only relevant for the package of interventions for rehabilitation, but for many products the WHO is developing. It is impossible without people who contribute to this. So our products are actually not developed by us, they are developed by the people who use it, who are meant to use it, and to have the experience. So for the package of interventions for rehabilitation, more than 700 people globally contributed. And without them, this package would not exist. But I will tell you more about this tomorrow. So my keynote is about the WHO Rehabilitation 2030 initiative. And I want to start with a slide that we used to show when we started with this initiative. It started around 2017. And at that time, we talked a lot about there is a need for rehabilitation. And many people know this. But the reality is there is low demand, specifically demand to WHO, to support them in increasing access to rehabilitation. And the assumption was that is because there is a low awareness of what rehabilitation is and what the benefits of rehabilitation are. And at the same time, it's not only the low awareness, it's also the supply that was not asked or provided for rehabilitation because there was low capacity. Capacity maybe in relation to, again, what is rehabilitation and how rehabilitation services need to look like, but of course resources that are not available in countries. Now, rehabilitation is defined as you can read here. I will not read this. I just want to make one point here. Rehabilitation is not only for people with disability, it's for people with limitations in functioning. So that means it's for people experiencing health conditions, inclusive of people with disability. But that was one misunderstanding that we need to clarify. Many, many more people than people with a disability can benefit from rehabilitation, and rehabilitation can even contribute to prevent disability. I will get back to this. Today we know more about the needs. We have numbers. So you can see here the global rehabilitation need from 2019. It's already 2024, so the number will be even higher. In 2019, it was an estimate that 2.4 billion people globally could benefit from rehabilitation. And also, it's also worth to look into the increase over the 30 years from 1990 to 2019. It's an increase of 70% globally. And it will continue because of the aging population, not only because of aging population, but also because of better health care. So nowadays, people survive because better immediate care, and then they also have need for rehabilitation to recover fully. But I also want to share the numbers for India from 2019. So 410 million people in India could benefit from rehabilitation. That's about the sixth of the global population. So if India meets the needs, this will be a huge contribution to people in need for rehabilitation. But also, please have a look at the increase of the need. It's 90% because of the growing population, but also the aging population. So, and again, these are numbers from 2019. In 2024, the numbers are even higher. This is a picture that shows the increase across disease areas. And you need to know that these numbers have been developed based on 26 conditions only. So there will be even more, because not all the conditions that would benefit from rehabilitation have been included in this analysis. But you can see the increase, and I only want to point out here that the highest needs are in relation to musculoskeletal conditions. But I want to disentangle this picture a little bit. So in India, the leading cause for rehabilitation needs are fractures. Globally, it is low back pain, but in India, it's fractures. And I want to highlight here, have a specific focus on injuries. So prevention of injuries is extremely important, but it's not completely successful until now. And I think traffic injuries play probably a major role. But the fractures are there. And fracture is also a good example because rehabilitation, if it's provided timely, that means early, immediately after the onset, you can prevent disability. So this is really important to take into account. I also want to show the next image about sensory impairment, which play an important role in India, which huge numbers of rehabilitation needs. But I also want to show these two figures that show the needs in relation specifically for children, such as disorders of intellectual disability and cerebral palsy. So there is a huge need in rehabilitation needs in children. And as well, there is not that much need in numbers, but I want to show that picture on dementia. And you can see here the need is increasing even more rapidly. It has tripled since 1990. So the need for rehabilitation in people with dementia will going to increase rapidly. And I just want to show some other images that relate to chronic conditions which will also increase, such as low back pain, which is the second leading cause in India, COPD, but also cancer. And I want to show cancer because it is also often forgotten that people with cancer benefit so much, so incredible much from rehabilitation. The number compared to the other numbers is low, but you can also see it's increasing rapidly. And please keep in mind how much people with an experience of cancer benefit from rehabilitation. I also want to point out who benefits. It's, of course, it is the individual with improved functioning, but also with prevention of complications, but most importantly, if improved participation, going back to work, going back to society, and improve well-being. But it's so important, it's not only the individual, it is also the society who benefits if people receive rehabilitation. Why? Because there is less burden for families of carers. You all know how much families need to care for people with experience with limitations in functioning. That means not only the person with a rehab need probably cannot go to work and contribute economically, but also families and carers. And this is important specifically from, I think, from a political perspective, how much costs can be reduced and how much the productivity of a country can be increased if people have access to rehabilitation. Now, all this in mind, the Rehab 2030 initiative was launched in 2017, and our vision is very closely related to the vision of universal health coverage, that everyone who needs rehabilitation receives quality services to optimize and maintain their functioning in everyday life. That is our vision, and I assume that's also your vision. With the launch of the 2030 initiative, it was agreed to have 10 action steps. So these action steps were our action steps where we were asked to work. I will not go into each of the steps. I want to summarize what we are doing because I can imagine many of you do not know what actually are we doing. So we are producing evidence, we are creating capacity, and we're supporting countries. And this takes place not only at headquarters, but at the regional offices and the country offices. And now I want to go specifically what we did for rehabilitation when we say producing evidence. You have seen the numbers, and the numbers were so important to raise awareness, to really show if we integrate rehabilitation in our health system, how many people will benefit? And you can see the number of people who will benefit are huge. But another example of evidence is a package of interventions for rehabilitation where we not actually have produced the evidence, but we have looked for the existing evidence, and with the help, or it was the work of the people in the development groups of these packages that summarized the evidence and that agreed on the evidence and the interventions that should be available specifically in countries with low resource context. Our products are organized according to the building blocks and assistive technologies and emergencies, and there are many. And sometimes sometimes it's a bit overwhelming to have that many products. So people who see that need to make decisions, okay, but where should we start with? And I will not go into each of the products, then I would need to talk an hour or so. I just want to highlight some. So there is a guide for action. That is a tool that helps countries in doing assessments of the situation of rehabilitation in countries. And following an assessment, which is quite comprehensive, I have to say, but also to do a strategic planning. In many countries, this is the first step, so there is a tool for that. There is a tool that can be used to evaluate the existing workforce in a country. It's also important to know about this because if you want to implement rehabilitation, you need to know, do we have the human resources and where do we need to strengthen the workforce so that they are able to deliver the interventions. And then the package, I will go into the details tomorrow, just some few words. The main purpose of this package is to support ministries of health countries in the planning, budgeting, and implementing rehabilitation into the health system by providing information on the type of interventions and the material and human resources that are needed to deliver the interventions. It is very important. It should not be misunderstood. The package is only 20 health conditions. That was doable in 5 years. But you all know there are many more health conditions that benefit from rehabilitation. So please don't misunderstand that if you do something for these 20 conditions, then people in your country are addressed sufficiently. There are more conditions that benefit. And this tool provides, as you can just see here as a snapshot, the type of interventions where there is evidence for. In addition, for each of the intervention that is included in the package, the material resources that are needed, the minimum material resources that are needed, and also some information on the workforce. And a last tool that I want to show, and we must not forget, everything depends on, is there sufficient financing? Because the interventions and the packages of care is not meant that people pay out of pocket for it. So there need to be funding mechanisms that make sure that people have access to these type of interventions without paying out of pocket. And so therefore we have a document that shows examples how funding for rehabilitation can be integrated in funding for health services in general. So we also support countries, but the main work is being done by the people working in the countries because they know the countries much better. But in the beginning, we often also, from headquarters and from the region, go to countries. And there are many, many ways how we provide support. As you can see, supporting doing such situation assessments or workforce evaluations or developing benefit packages inclusive of rehabilitation or doing webinars on rehabilitation products and tools or even hands-on training on how to use specific tools that we produce, and many more, such as a conference like this. Until now, it's nearly 70 countries where we have been working, and the numbers of countries where we provide support is increasing. I don't want to miss the opportunity to just show that we also have one other area of work that is at the moment still under the WHO head. This is the World Rehabilitation Alliance. I've mentioned this in my remarks earlier. So this is a group of rehabilitation stakeholders who work in 5 different work streams, and the main purpose is to raise awareness at all different levels and advocate for the need for rehabilitation. And this is necessary. This cannot only be done by WHO. This needs to come from the community, from stakeholder organizations who advocate for strengthening rehabilitation. Now, so you have seen, we know about the needs. We have tools that help to strengthen rehabilitation in countries, and we provide support. But one of the major milestones we have achieved last year is a mandate to the member states of the World Health Organization. With the launch of the resolution on rehabilitation, the strengthening rehabilitation in health systems, now member states are asked, or there is a call, that they strengthen rehabilitation in health system. And this is just a shortcut of the resolution. Don't worry, I will not read this, and you don't need to read this. I only want to highlight some of the items and the calls to member states, such as it's about strengthening financing mechanism. Why? Because in the next hours and days we will talk about these aspects that are addressed in this resolution. We will talk about budgeting. We will talk about rehabilitation needs to be available across all levels, from primary to tertiary care. We will talk about evidence-based interventions, specifically tomorrow, and that is a must. So if countries invest in rehabilitation, they need to make sure the interventions that are being delivered, the money they spend into this, they are effective, they are evidence-based. In interventions that are not effective, they do not need to pay for it. We will talk about workforce that needs to be strengthened, and we will also talk about research. So the agenda of this meeting really perfectly aligns with the resolution. And keep in mind, member states they received a call to work on this in the future. So from our perspective, let's work together to make sure that the vision of Rehabilitation 2030, that all people in need have access to rehabilitation, become reality. I look very much forward to work with you together on this for the next 2 days. Thank you.
Thank you, ma'am, for giving us insights on WHO Rehabilitation 2030 initiative. Now, as we progress with the session, it gives me an immense pleasure to introduce our first invited speaker, Dr. Tashi Tobge. He is a distinguished professional currently serving as a regional advisor for disability, injury prevention and rehabilitation and World Health Organization Southeast Asia Regional Office. He was the former director of Khesar Galpo University of Medical Sciences of Bhutan for 11 years. He was the chief program officer at Ministry of Health for 7 years, where he developed and implemented various strategic plans, conducted research, and extended the collaborations nationally and internationally in vector-borne diseases, including malaria and control program. Kindly join me in welcoming Dr. Tashi Tobge to the stage to address WHO Southeast Asia Regional Perspective of Rehabilitation and Assistive Technology.
First of all, greetings from the WHO Southeast Asia region. Also, I would like to thank the MGM Institute of Health Sciences for giving us this opportunity and taking this agenda forward, not only in India, and hopefully we look forward working closely to take it for the region and also towards the global agenda. WHO Southeast Asia region, we have 11 member states. That includes Bangladesh, Bhutan, Democratic People's Republic of Korea, India, Indonesia, Maldives, Myanmar, Nepal, Sri Lanka, Thailand, and Timor-Leste. These 11 countries constitute around 1/4 of the global population. So therefore, if we can move an agenda in this region, we serve a lot of people. As you heard this morning, that rehabilitation is not a separate component, it's not a luxury thing. It is and it must be an integral part of every health services. It should be as a right of every individual to get access to the rehabilitation services. There has been a global movement, a lot of global milestones. I'm just highlighting this one. At the initial phases, there are a lot of rehabilitation has been thought as it is a service only for the persons with disability. This is not fault of any individual, but there was a movement in that direction, which was a cause of not having rehabilitation services across the population level. But in 2017, as Alex rightly pointed out, the global movement towards rehabilitation reignited, and there has a mandate, 10 key principles that could serve as a basic guidance to providing a quality rehabilitation services, a basic guidance for the countries to work towards the rehabilitation services. And in 2023, as Alex rightly pointed out, the World Health Assembly had the resolution focus on strengthening the rehabilitation services. So this is the key, and the momentum is there at the global level. And now with the champions in India at MGM with Rajni, we have ICMR, we have Mobility India, and we have Government of India, everyone working towards and providing the rehabilitation services. This is just to reinforce what Alex mentioned, that in 2017, the movement has been ignited, and the Rehabilitation 2030 agenda has been set forward. Some of the key areas that's already highlighted. And in 2023, the resolution, and Alex already highlighted the key components. The member states, in WHO we call member states, one, to raise awareness on rehabilitation, rehabilitation financing, develop all levels of care, including the primary health care, strengthen rehab workforce, generate rehab information, undertake health policy, integrate an emergency preparedness for rehabilitation. So you can see that wide array of rehabilitation needs. And this is mandated by the member states at the World Health Assembly. So the global movement is already there. Now we need to take this forward and not only leave it at the resolution level, but to ensure that this is reached to the people in need, those who need the rehabilitation services. At the regional level, there are various factors that might need our rehabilitation services. For example, if you take the age factor, the demographic shift towards the older population is already there. that might need a lot of rehabilitation services. And injury is one of the major causes of health conditions that will need rehabilitation services. We are doing a lot of work on injury prevention, but more work needs to be done as well. Rehabilitation services in the CRO region, Southeast Asia region, if you can see, 2 in 7 people could benefit from rehabilitation services. And 590 million people experience conditions that could benefit from rehabilitation services. And as highlighted by Alex, 410 million people in India. So there is a huge number in the region and India that would benefit if you have integrated, if you can provide a quality rehabilitation services. And also in the region, the data is not there to really project, although we have projected data, but the real evidence is lacking to frame a policy framework, to show to the policymakers, to the politicians that the need is there. Some of the key conditions, health conditions that could require rehabilitation services in the region, the 4 conditions, low back pain, vision loss, COPD, and fractures are the 4 main conditions of which the rehabilitation services are required. This is in the regional context. But not to say that all other or neglect all other conditions, but these are the 4 key conditions. And if you can take care of the major conditions, especially at the primary health care level, we can address a lot of issues. Assistive technology is one of the areas that has been taken forward in the region, and it is one of the important components when you talk about rehabilitation services. As provisioning of assistive products has to be an integral component. And in the region, although globally around 2.5 billion people are in need of at least one assistive product, in the region, on the average, only about 12% of the need is met. So there is a huge gap of unmet needs of assistive products. And thanks to ICMR led by Ravinder Singh, now we have the priority assistive legs list for India. And also we have now the momentum gathered on provisioning with NITI Aayog coming in the central forefront, and all other government agencies and the institutions and the NGOs working together to provide the rehabilitation services and also the assistive products. The global report, the great report on assistive technology highlighted some of the key areas. One is access. Most people access assistive products are from private shops. Therefore, the access has become a problem. It has to be provided from the health facility. And they pay out of pocket, and most people cannot afford it. High cost can be a big barrier in accessing assistive technology. In terms of emergency, these assistive products are not there. So as Alex highlighted, some of the WHO tools, how this is implemented at the country level. So we have one tool, Rehabilitation Guide for Action, and that was done, taken forward. And in Myanmar, Nepal, Sri Lanka, we did a situational assessment. So in that situational assessment is moving towards developing the strategy for the countries, and therefore, and then by implementing that strategy, the people benefit. So that we have the global mandate, and to fulfill the global mandate, WHO develops its normative works, technical guidance documents, and the technical guidance documents are translated at the country level and the provision of the services. So the flow is there. I just wanted to highlight that how these global tools are translated and benefiting the people in need at the country level. Some of the key works in the region that has been done in terms of the rehabilitation and in terms of the strip technology. These are some of the global tools that we have, and the member states that have carried out these tools. There's still a lot of work to do, but the progress is there. And this is a little bit outdated, as APL, for example, we have India now, we have already have the APL list, priority estate product list. So the key message out here is rehabilitation is for all population who need it. This includes people with disabilities as well as many others. Rehabilitation services is an essential health service and needed at all levels of healthcare, and that to be integrated and along the continuum of care. Rehabilitation is not only at tertiary level, it has to reach at the community, and the continuum of care should be there. Referral pathway has to be there. Developing rehabilitation requires strengthening of health systems to provide rehabilitations. That is what exactly the Rehabilitation 2030 has ignited, improving the health systems. If you can improve the health systems, rehabilitation services should be the integral part of the health system strengthening. As I highlighted, rehabilitation is required by all. If you are, whether you are a sports playing golf or a hardworking lady, people need rehabilitation services. And with these principles in mind, with these key mandates in mind, the regional office and the region is focusing some of the key areas to ensuring or promoting the rehabilitation to be an integral within the health service systems at all levels of care, accelerating the provisioning of rehabilitation services, for which we are trying to develop a regional framework where the member states can take guidance to develop their strategic guidance documents, policies, and support and build capacity in the countries, increasing the leadership, political prioritization, and resource mobilization for the member states. We need a lot of support from the government, a lot of support from the academicians, a lot of support from the NGOs. We need to work together so that we all speak in the same word, so that we all fight for the people in need who are in need of the rehabilitation services. And WHO has always developing the norms, standards, and technical guidance with support from HQ, regional office, and the countries, and generating information, shaping the research agenda, and monitoring progress. So WHO World Health Assembly resolutions have mandated WHO to report what is the progress of the resolution to the member state, to the World Health Assembly, and then we have to report the progress. So with this, I thank all the delegates out here for patiently listening to me. Thank you.
And assistive technology. Now moving ahead, I would invite our next speaker, who is a prominent health professional, Dr. Mohammad Ashil. He is a National Professional Officer at Injuries, Disabilities, Assistive Technology and Rehabilitation at World Health Organization. As a passionate institution builder, he has transformed a special school into a center of excellence in rehabilitation sector. In addition, he has also established a state-of-art center for post-traumatic spinal cord injury at National Institute of Physical Medicine and Rehabilitation with Advanced Technology. I would welcome Sir.
Thank you very much for this opportunity, and moving forward from where my colleagues has stopped. So Dr. Alexandra and Dr. Tashi has made the context clear on why we require a mainstreaming of rehabilitation in the health system across the globe and also specifically in India. So as you all know, it's not an easy task, and it has never been an easy task in bringing any new change, especially in the area of disability and rehabilitation. So I will begin with a story to break the monotony of academic discussions. So I'm sure that everyone recognizes this building, right? This is the Capitol building in US, Washington. So something happened here on March 12th of 1990, which changed the history of disability inclusion, rehabilitation, and also accessibility across the globe. Why it's changing by itself? So that was, in the history, it's known as the Capitol Crawl. So the congressman on that day was discussing on whether the ADA, that is Americans with Disabilities Act, need to be enacted or not. And there was a lot of argument in opposite to that, saying that why do you want to have an act specifically addressing a special category of population, and whether it's even relevant to have a kind of an act for a population. So in order to make the congressmen aware of the situation and also make a significant change in the way they look at that, few people around, somewhere around 1,000 people came and to the Capitol where the discussion was happening, and they crawled on the staircase. They left their wheelchairs and crawled up the staircase of the stairs of the Capitol building. And due to one of the contributing factors which led to the signing of that ADA was this movement. And there is a good book for that, actually. It's worth reading. That's All the Way to Top. It was titled very nicely, that All the Way to Top. It is based on the life of Jennifer Keelan Chaffins, who was one of the person on wheelchair who led the entire movement. So similarly, if you take the history of small modification which happened in this sector, for example, the curb cuts. You know the curb cuts in the roads, this one which actually connects these things. So Ed Roberts, he fought for around 10 years to make the change in the Architectural Barriers Act, which led to these curb cuts. But what came after that is what we call commonly as the curb cut effect, which is very relevant to this context. That is, when they brought these curb cuts, they realized something, that it's not only benefiting the person with disability, it benefits older population, it benefits mothers with carrying their babies on a trolley, and people coming after shopping. Everyone was benefited out of that. So a small intervention, setting up of a small curb cut, which was primarily built for person with disability, actually had a big impact on the life of more than half of the population of that land. And even now, when we see our mobile phones, if you see our mobile phones are made in a way that what we call as digital curb cuts, wherein which if the mobiles can be used by a variety of population. The universal design of mobile is such a way that it can be used by variety of population. Even if you are deaf and blind, then also still the mobile phones we came after 2020, which is to be sold in many nations, actually have this property of can be used by deaf and blind. So similarly, what we need to understand when starting rehab services is that it is not for person with disability. It has the curb cut effect across all people. So strengthening rehab has a curb cut effect for everyone. So when we define it, as Alexandra and Tashi has cleared, it's not just only for person with disability, it's for people with any functioning problem. So anybody in rehabilitation, it can be very transient for post-surgery post-injury, diseases, illness. So this, a system of that need to be strengthened. So when we say about, when Alexandra mentioned about 410 million, and Tashi also said about that, when we say 410 million, as she clearly pointed it out, it's not just the 410 million you are seeing. Every one of us would be requiring some kind of rehabilitation. And if you look at the assistive devices, there is an interesting study which says that in a population with an average lifespan of 72 years and above, an average person spent his 8 years of life with some form of functional limitation, which forms around 11% of his lifespan. So every one of us somehow would be requiring an assistive device and also a rehab need. So it is already mentioned, it has been reiterated. India, why is showing this again and again? Because India is one of the signatory, and India has taken one of the lead in actually when we say that this rehabilitation need to be part of health system. India has taken the lead of actually getting it through the World Health Assembly. So currently, what is the factors which are causing this unmet need? So if you see the limited, I have tried to classify into three levels. Like this, limited access to services. One, of course, as every one of you know, there is a huge shortage of professionals in this area. And the second one is unequal distribution. So unequal distribution, not only within the urban-rural setup, within the institute, within the medical setup, there are, if you can see the unequal distribution across various levels. So even the institutions, if you see the rehab institution in India, how many audiologists or speech therapists are there in the AAPMR? If you take AAPMR, then how many physiotherapists or occupational therapists? Largely there are some physiotherapists, occupational therapists in AISH, or Institute of Speech and Hearing. But if you see there is a very kind of fragmented fragmented kind of a skewed distribution of professionals. And most important, the financial barriers. Not only the funding part, but also insurance. We had a NITI Aayog and WHO had organized a workshop last year looking at the funding of insurance models for supporting rehabilitation and assistive technology. How do we find the money for that? Currently, there are multiple cases happening in courts on not only a person with disability and a person with functional limitations would be requiring some kind of medical insurance. It can be for other diseases for them and also something related to the disability and assistive technology. But currently this area is largely unexplored and there is a lot of lacuna in this. Then lack of awareness and information, limited awareness. Like if you ask a person, there are the studies showing that that hundreds of thousands of people are as isolated in their homes after stroke, or basically even for a small function limitation, they get bedridden and they really don't know the awareness of where to go, what possibilities they have in the rehabilitation. So, and social stigma is another reality now. Then systemic challenges, fragmented rehab delivery care system in India. If you see, the rehabilitation primarily forms in the domain of, in the functional domain or in the constitutional domain of social justice department. But that's another reason why rehabilitation services is not currently integrated with the existing healthcare delivery system, because the primary department which is dealing with rehabilitation is the social justice department, which is not into the delivery of healthcare services. There's many other issues in the fragmentation of the rehab care services. I'm not going to go into details of that. The another is that everything revolves around policy, and there is definitely a policy gap. So how do we meet this unmet need is, if you put it very simply, it's not as simple as that, but still saying, create awareness, train professionals, improve access and coverage to rehabilitation, and strengthen systems, if we can actually put it very simplified. So how does a package of intervention help in that? So I was trying to kind of find a definition for package of intervention for rehabilitation, easy definition. So it's a comprehensive set of evidence-based intervention guidance designed to address the rehabilitation needs of individuals with various health conditions across the levels of care, if you can put it like that. So how do it help? Actually, we will get a detailed introduction to the package of intervention tomorrow by Alexandra. But just how is this going to help us? Is that what package of intervention gives us is where we have to intervene, the assessment to be done, the interventions, evidence-based interventions in this, and even including the secondary conditions related to a condition. This is just an example, the stroke example. So what are the material resources required, what are the assistive products required, what are the equipments required, consumables required, and what are the professionals required, and even the timing for that. So when we identify this, and also the material resources also are identified, using this, what we can do is that, one, we can develop strategies for health system strengthening for rehab at various levels. For example, at the primary level, what all things need to be provided, what all basic care can be provided, what are the equipments required for that, what would be the professionals required for that. That can be, this PIR can serve as a guidance document in developing that. And another one is existing, the facility, doing a gap analysis of the existing facilities on where do we stand now and what are the gaps in terms of resources, human resource, training, which need to be plugged in. So then training of professional, obviously, making curriculum, training of professional, making training modules, all these, the package of interventions can be used. And designing health packages. How do we design a benefit package? How do we design a policy package? How do we design an insurance package? That can also be done through that. Research, obviously, and also understand the progress, timely progress. So, when to realize, this is my last slide. So to realize all these things, what we would require is kind of a concerted effort that involves technology, that involves team, that involves human interaction, that involves collaborative work, that involves science into that. So this is a slide which I usually use for the emergency care, but I can't find a better slide in this when it comes to use of technology, use of human resource, how the training can actually do that. Like one classical example of where time matters, where technology matters, where teamwork matters is F1 pit stop. You know F1 pit stop, right? Formula 1 pit stop. Formula 1 pit stop is a place where the cars during a Formula 1 race just come in and they have to repair their tires. Everything has to be done in the shortest possible time, and you have to make your vehicle roadworthy and win the race. Every microseconds counts. So that's why technology, teamwork, everything, people research into that, how to actually make the best use of time there. So one classical example I'll show what change it can probably make. So this is a Formula 1 pit stop in 1950. So when the car comes,
changes the
they
tire.
are going to change the two.
Only 4 crew members, including the driver, are allowed to work on the car. It's a tense time. Holland stays in his seat, anxious to get away. Let's watch.
That they are changing the just 2 wheels here.
The tires are changed at last. A crewman polishes the windshield as Holland moves away just 67 seconds after he stopped.
Just 67 seconds. Just 67 seconds is a very good time at that time. It was a record at that time. Now the training, teamwork, everything. Now what you're going to see is changing of 4 wheels. This is how. That happened in 1.6 seconds. And I was thinking that what could have probably happened there? What is the process involved in that? You cannot actually change the process, no? The vehicle comes in, someone lifts the vehicle, someone unscrews the tire, take it out, put the next tire, put it again from the four sides. Just telling that took me 25 seconds. Doing that took 1.6 seconds. And how did they do that? They developed the technology, they developed the teamwork, they developed the know-how, they did the training and make sure that things are moving. And as our Chancellor said, movement is everything, and let's keep it moving. Thank you.
Thank you so much, sir, for addressing on the advocacy needs. Moving ahead, I invite Dr. Rupali Roy, Assistant Director General, Directorate General Health Services at Ministry of Health and Family Welfare, Delhi. She has 18 years of experience in the field of public health and 9 years of academic experience. Dr. Roy has worked in National Center for Disease Control, Emergency Medical Relief Division, Trauma and Burns Division, National Leprosy Eradication Program, International Health, National Program for Control Blindness and Visual Impairments, National Micronutrients Program including iodine deficiency disorders, National Program for Prevention and Control of Deafness, and Blood Cell and National Blood Transfusion Council. I welcome Dr. Rupali Roy to deliver her talk on health policies pertinent to the rehabilitation in India.
Thank you, organizing team, and especially Dr. Rajni ma'am. I can't see her. She must be busy further arranging some work. For giving me this opportunity and to talk in this topic. My topic is Indian government health policies pertinent to rehabilitation. As I am working in this field since last 2.5 years, and since many months, I was thinking there are so many gathering, meeting, conference on various diseases, non-communicable, communicable disease. But I was really missing some gathering on who are really talks about this personal disability and who require rehabilitation services. So I'm grateful to MGM Institute for organizing this conference and wishing a great success. And also wishing many more conferences like this in future. As we know, good health and well-being are foundation of human resource quality and determine the development strategy of any country. National health policy under Ministry of Health, Government of India always focuses on universal health coverage. Since morning we are hearing this, and it firmly identified as a target of SDG Goal 3, which encourages to ensure the equitable, high quality, affordable health services, including rehabilitation services. And it also talks about to reach those services up to the last level of health care facility. Further, the Alma Ata Declaration also in 1978 stated comprehensive primary health care should include promotive, preventive, curative and rehabilitative care. There are three approaches to a rehabilitation, mainly institution-based, outreach-based and community-based. So, as a representative of Ministry of Health, Government of India, we will talk about only medical rehabilitation. Though, as Dr. Ashil said, if we talk about the nodal ministry, that ministry is Ministry of Social Justice and Welfare. India ratified the UN Convention on the Right of Persons with Disabilities in September 2007, and it was in force from May 2008. Further, as we saw in the WHO slide also, time to time on various documents, WHO talks about the strengthening of rehabilitation services, assistive technology and community rehabilitation. So the major reason which are contributors to increase the number of persons with disability and who require rehabilitation services are communicable and non-communicable disease. Polio was one of the most important factor, but cause, but which was we already know eradicated. But still there are some other communicable diseases like leprosy, measles, Japanese encephalitis are still prevalent. In addition to these communicable diseases, there are non-communicable diseases also presently are in increasing trend. diabetes, hypertension, stroke, cardiac illnesses, cancer, road traffic accident also, as Dr. Alexandra shows us that it is a major contributor in India who require rehabilitation services. Further, the growing, changing demographic trend that is growing, the elderly population in the country, and also these people we know are suffered mostly age-related degenerative disorder, and that also is a contributing factors. So, keeping in mind these causes, Government of India, Ministry of Health, time to time launched various health programs to deal with diseases with objectives for early detection, giving treatment on early, and providing services including rehabilitation services. As Dr. Ravindran during the inaugural session in the morning, he emphasized all the national program has a component of rehabilitation services, but still this area has to need further strengthen. And this, as we know in India, since the first national health policy was in 1983, since then in the health policy always rehabilitation was one of the component. Then the various health program, as I mentioned, National Leprosy Eradication Program, National Program for Control Blindness, then National Program for Non-Communicable Disease, for deafness there is a national program, National Mental Health Program, Rashtriya Bal Swasthya Karyakram. That is one of the important program under which there is a scope and opportunity to diagnose the child at very early age if he has some disease, disability, and any developmental disorders. So there is a scope, we can provide rehabilitation services, maybe we may prevent the disability at very early age. Then there is a national program for health care of elderly, the national palliative care. These all the health program. Sorry, I have missed one program, that is a national health program for trauma and burn injuries, and which is the leading cause who require rehabilitation services in India. Then Ministry of Health, Government of India also focusing on increasing the personal strength of person working in the field of rehabilitation. There are various institutes, All India Institute of Physical Medicine and Rehabilitation, which is in Mumbai, and I know Director AIPMR is invited in this conference. Then there is National Institute for Medical Health and Neurosciences, Bangalore, All India Institute of Speech and Hearing in Mysuru, Central Institute of Psychiatry, Regional Institute of Mental Health, these are there to deal with the issue of mental health. Then there are leprosy, 3 leprosy institutes are there all over the India to deal with the disease leprosy. These all institutes are responsible for providing services who are developed disease for specific to this cause, and also providing rehabilitation services along with training, and they are also responsible for doing research. As I mentioned, the last national health policy is which came on 2017, and it also has a provision for improving healthcare services for persons with disabilities. Under that health policy, Section 2.2 talks about reducing inequity. Section 3.2 talks about preventive and promotive health. Section 4.5.3 talks about leprosy elimination, and Section 25.1 strengthening knowledge for health. That means that rehabilitation is always part of government health policy, and that also providing affordable health care to the person with disabilities. Like public health facilities are providing almost free of cost medicine and treatment and services to the person with disability. Then there is a Pradhan Mantri Bharatiya Jan Aushadhi Kendra, which provide medicine to the all patients, all persons required medicine at very low price. Then Ayushman Bharat Pradhan Mantri Jan Arogya Yojana is an insurance program under the Ministry of Health, where 5 lakh rupees per family per year are providing as insurance coverage. As in the last presentation, Dr. Ashil said NITI, Aayog and WHO is talking about insurance coverage. Maybe we, for that assistive technology, maybe we can explore further to strengthen this. Further, for affordable health care, Ministry of Health in the various health care organization, they have done some structural changes also so that the person with disability can have easily accessible health care in the healthcare organization. Then tele-rehabilitation also is one of the important topic, and the ministry has really wanted to make it further strengthened. Telemanas is one of the successful program which is responsible for providing comprehensive mental health care service under Ministry of Health. Presently, as I mentioned, All India Institute of Physical Medicine and Rehabilitation is also working in collaboration with CDEC for further developing tele-rehabilitation services. Ministry of Health also included this topic in the medical curriculum of UG and PG medical students, and NMC is focusing on training of more doctors in physical medicine and rehabilitation and to provide knowledge of assistive products to the medical graduates. Then, as I mentioned, already focusing on for training of some manpower in this field. So, along with PMR, orthotics, prosthetics, physiotherapy and occupational therapy also under the list of Ministry of Health to improve the capacity building. Time to time on various documents related to rehabilitation services, either in NITI Aayog or in WHO or in any other ministry, maybe sometimes the educational ministry and then Ministry of Women, Child and Development also approaches Ministry of Health to provide technical input which are being developed. So we provide input. We have recently finalized and released the document on recommendation for medical rehabilitation of person injured after an earthquake. And Dr. Sanjay Wadhwa sir is here. He was the chairperson for finalizing that document. He is from HOD PMR AIMS Delhi. Then we have also finalized the minimum standards for prosthetic and orthotic centers. Then about the RPWD Act. As we all know, though its act is under the Ministry of Social Justice and Empowerment, but Ministry of Health has a very important role in implementation of medical rehabilitation services to the person with disability. And then this aim also, this act also have a aims to protect and promote the right of person with disability. It covers education, employment, accessibility and social inclusion. So, as a part of this act, Ministry of Health, in close collaboration with Ministry of Social Justice, recently revised the assessment guidelines for person with disability, and it was notified on 14th March 2024. For revising this assessment guideline, 8 subcommittees were formed, and these members were from the various reputed institutes all over the country, and they have finalized the criteria for assessing a range of disability, provided and maintained consistency and uniformity. This guideline also included appendices and proformas for thorough evaluation of person with disability, and it is aligned with international standards. In these revised guidelines, we have also revised the medical board authorities for doing the disability evaluation and for certification. As I said, like I want to meet this gathering, include the physiotherapist, the orthotics, prosthetics, clinical psychologist, rehabilitation psychologist, speech language pathologist, audiologist. These are the multidisciplinary team are required for complete evaluation of a person if the person is suffering for various kind of disabilities. These are the 8 subcommittee, and again for locomotor disability, Dr. Sanjay Wadhwa was the chairperson for doing the work. Then recently we also finalized the accessibility standards for healthcare, and it was notified on May 23 by Ministry of Health, which actually helps and guided so that every person with disability can access healthcare services and is able to get timely, high quality, affordable rehabilitation services. Then we have also finalized healthcare accessibility training manual for staff, because after guidelines for the infrastructure, we realized like staffs in the hospitals are not that much sensitive enough to deal the person with disability of various category. So that's why we already trained around manpower from 23 institutes. Training is started and it will be going on. So person who will deal, since the person with disability enter to the healthcare premises, since then in fact we have in that manual try to sensitize the guard also, security guard, so that those persons have a hassle-free experience in the healthcare established. Then for auditing and for doing whether the healthcare accessible standards is following or not, we have also drafted the checklist, and it is in the under finalization mode, so it will be finalized. Again, to improve the accessibility, recently Ministry of Health issued a notification and advisory, like in any training like this gathering, we may have a one person representative of various disabled category also to hear their challenges and to include in any guideline whatever we are finalizing. And also we may keep one sign language expertise during, so that kind of advisory was issued. For every meeting there will be sign language interpreter, so that if someone having a problem with hearing, they can understand the conversation during the meeting. Then in our hospital also various infrastructure, like all our hospital are accessible person with locomotor disability, or if the person having blindness or low vision, so that they can have a, easy access. And also we have issued a notification for all health related website. It has to be accessible to the blind people, and that's what we are emphasizing. All institutes, all government website, it has to be accessible, and Ministry of Telecommunication also has an important role for implementing this. So at this juncture, it is important to estimate the magnitude of the problem. Though we have from say in the morning in the WHO presentation, the various type of disabled person who required rehabilitation services, that data was presented, but still more focused data is required on various category of disabled person with disability, so that specific rehabilitation services can be developed further. And for this is the best like group, and I would like to take the opportunity to request all stakeholders present here to provide evidence-based and expert recommended informed recommendation to guide the government and to guide the stakeholder for developing and extending rehabilitation services, and to also help them to develop the strategy how to reach at the last level, at the community level. Then advocacy for mainstreaming is also required, and it requires commitment across all these sectors and built into new and existing legislation, standards, policies, strategies, and plans. As Dr. Ashil said, AI NML specific program is very important. Though I saw from the slide that training has enhanced, but the manpower number, trained manpower number also from the earlier occasion, it is also increased. So in the second slide, the number of trained manpower was much more than the first slide. I'm talking about that Dr. Ashil's presentation. So capacity building and sensitization of healthcare providers and program managers, multidisciplinary staffs are very important. Thank you.
Have another speaker who will be joining us online. Dr. Ashu Grover is an accomplished medical professional serving as head at Implementation Delivery Research, Indian Council of Medical Research. Dr. Grover joined Indian Council of Medical Research as Senior Research Officer in 2005. She has established multidisciplinary research units in government medical colleges, model rural health research units in 25 states across India. She has contributed for special program at medical colleges to develop research projects under Research Methodology Cell of ICMR. Contributed about 50 research papers in Indian and other foreign journals. We would like to welcome ma'am.
Good afternoon, everyone. And first of all, let me thank the Mahatma Gandhi Mission for organization in assistive health technology and physiotherapy. And this is my great privilege to be part of this audience where I had attended this inaugural ceremony as well, and I could see the visions and speeches from the various dignitaries, offline and online both. So, and special thanks to Dr. Rajani, and she has been very dynamic, very passionate, very influential, and very, persuasive to make this event happen. And I remember that when we met few months ago, and this conference was planned, and she requested me to be part of this event and physically, but unfortunately I can't make it physically because of certain meetings committed at headquarters. So my apologies for not being there with all of you, all my friends, dears, colleagues, and many academicians are there attending this event. So many congratulations for organizing this very important thematic conference on rehabilitation, and special thanks to World Health Organization and co-sponsors NITI Aayog and other non-government organizations who have contributed in making this conference as a success. I would be talking something about the perspective of ICMR and how do the different uh, initiatives have been undertaken here, and how do we do the prioritization. So may I re-ask that, is my slides visible? Is my screen visible? Okay. Okay, good. So when we talk about the rehabilitation, this is a very important path of care, continuum of care cycle, continuum of care spectrum of the entire, uh, you know, events what may happen in any due course of the anybody's in the lifetime. It may happen in the age of the childhood. It may happen in the age group of adolescents, adults, elderly, women, male, female, rural, urban. So anything may happen in any part of any course of the life, and that need to be properly curative. If it is not curative, if we cannot cure this properly, so they need to be rehabilitated. But how to do the prioritization, that itself is a tricky issue over here. So why we need to do the prioritization, that and who will do the prioritization, that's again an important aspect. So that is what I would like to share a few of my thoughts as a public health researcher and heading the division of implementation science at Indian Council of Medical Research headquarters. Why are my slides moving? Okay. So we see that we have this is a problem across not only in some of the parts of the country. This is a problem across the entire globe. And we can't say that only less number of people. So we have a huge, large number of person, especially from the age group of 15 year and onwards. Around 800 million have been suffering with any of the disability across. Could be related to the locomotor, could be related to the sensory, could be related to some cardiac event or neuro event, whatever. And among those, around 2 to 3% have the significant disabilities, and around 20% globally people are still living with the disability, which need to be engaged into the routine healthcare, so routine healthcare continuum of care, and to improve the quality of life. And across India, we have various age group. It advances from pediatric age group around 7% to around 90% elderly age group. So that's the spectrum of the disabilities in country, and it may, with the increasing rise of marginalization, the urbanization, and various risk factors like behavioral risk factor, it may rise as per if you're not going to take care of these particular aspects from the services aspect, from healthcare spectrum aspect. If you're not going to take care of such these population, may rise, exponentially. Um, but how do we get this evidence? How, which drives them to get a proper, such burdens? Before we set on the priorities, we need to align ourselves that who is contributing to such burden of diseases. Are we going in the right direction? Are we going correct data about it? Is it underestimated or is it overestimated? So I'll talk about India, where we have a large data sets which are contributing from national perspective and from the state health programs also. I think India, everybody who's attending this conference, those who are medicals and the paramedicals, they may know that India has a substantial amount of various data health sets. Still, the data which comes from the lowest territory of our Indian healthcare system, that is not properly utilized till it comes to the central level. There are efforts being done which can make the data more harmonious, more continuous, more standardized data, but still we need to do a lot. So that is what the estimates which I mentioned previously, my previous slide, may or may not be, maybe underestimated that way. And we need to improve the quality of the data, and we need to have the integration of the data, which I feel is one of the priority before we set in our rehabilitation services in India in a correct mode. And we have recently, last 5 to 7 years ago, we launched this Ayushman Bharat ABDM, Ayushman Bharat Digital Mission. And this is one initiative which is trying to integrate the various health data infrastructures across the country so that we can get a unique health identification number of all the beneficiaries, starting from the childhood till their entire life course of the events. We can count that what are the numbers for suffering from a particular condition, how many numbers require immediate rehabilitation, how many numbers require home-based rehabilitation, how many numbers require institution-based rehabilitation, and who requires an integrated care approach also. So first and foremost priority which comes to us is that we need to set ourselves correctly. We need to set our home properly in design, that so that we can embark upon the relevant information, so that we can have the correct policy, we can have the correct infrastructure laid down for those people who require this information. This is something which is again very, we should be not very proud of feeling that this is recently NFHS 5 data, and we have already getting this NFH National Family Health Survey 6 has already started in. And as we see that on the left hand side of my screen, you can see that that's a pie diagram which can say that, okay, we have the visual impairments, we have the speech problems, we have the mental health issues, we have the hearing disabilities, and far more, around half of the disabilities are contributed to the locomotor disabilities. And on the right hand side in the radar plot, you can see the age group by distribution, that around 75 and above, it is more of the elderlies who are suffering from more of the locomotor disabilities from that angle. And we have hearing disabilities rising from middle age to the elderly population, and so on. Our mental illnesses is also, though it is in the middle of that radar, but still it's a substantial number of people who are suffering from mental disorder. They really require rehabilitative approaches. Just to, we all know that as a physician, we know that all these disabilities, all these issues have a different approaches to address upon. Mental health rehabilitation has a different approach. Locomotor disability has a different approach to be taken care of. And hearing, visual, speech, and other aspects have different approaches to be addressed upon. We need to align our services in requirement of these different data sets which I am projecting. So that is the crux of the issue, that we need to have various multiple approaches to address the rehabilitation services in our country. And the below diagram, it shows that as the educational status across the various parts of the country, and that shows the different trends and different estimates about the educational, as per the educational status of the this disabilities across India as per National Family Health Survey 5. Coming back to some of the challenges which rehabilitative services which could count on, and these are based on certain published literature. And of course, the first foremost which comes up is the paucity of the services. One is that, okay, if we have visited any of the healthcare facility across the country, starting from our primary healthcare center level to the tertiary healthcare center level, if we see that, yes, we have all the clinicians who are sitting across various parts providing the clinical services, the curative services, providing the diagnostic services, but we do not have a dedicated facility at all the healthcare centers level which can address upon the rehabilitative services. This is one area which is not given much preferences in our Indian public healthcare system. We really need to align ourselves and make a reasonable amount of services available for these people who we can make better quality of life and they can be more productive for the country. Another services aspect challenges I will see is a multiple agencies. These multiple agencies, it could be the federal agencies, the public healthcare agencies, or the non-public or the private healthcare agencies. We have segregated, and I think there are many non-government organizations. They are doing tremendously, fantastic work across the country, but we do not know what kind of services they are providing. They need to be gathered together. So that is one challenge which we think of should be aligned into our public health system. And apart from that, there are various national departments, our ministries, which are working in isolation with the different perspectives, the different aims and objectives. For example, the Minister of Social Justice and this Department of this Disability and Rehabilitation. So, real need to cater about the quality of the provisioning of the assistive products to the various people who require such devices. Apart from that, we have various international organizations which are providing not only in India but across the borders also in different manner. We can see the Rockefeller Foundation, we can have the Bill and Melinda Gates Foundation, World Health Organization, Center for Disease Control, we have Indian Red Cross, International Red Cross Society. So many such agencies are there, but we need to know that how are these working and can we work all in unified approach. So that is one aspect I could feel is one of the. Another challenge I see is research on innovations. There are various organizations which are working to come up with the different products which are suitable to the person of disability, person of functional impairment who require like speech, for auditory, for hearing, for mobilization, for elderly care, for neonatal care or person with specially challenged children. So many things, many institutions are working on their, like we have the biomedical engineers, we have the clinicians. So we need to have more and more research, and which is still, it may have been done with various, the support of various organizations, but these need to be on board together. And we need to promote this area of research, of developing the innovations, sustaining the innovations, scaling up the innovations, and making these innovations available to those who are requiring such products. Another challenge is the capacity. Capacity in all aspects, capacity for the development of the innovations, capacity for reaching the unreached. We don't know how to reach some of the behavioral interventions. They may be required to have the reach to those people who require counseling kind of a things. That's also approach for the rehabilitation. Another is the low priority. This rehabilitation task is not given much priority. If I see the overall budget from various organizations, it will be less than 1% of all of the, the budgetary allocations. If it's not only for the budgetary allocation, but yes, even for various agencies like Ministry of Health and Family Welfare, the Ministry of Social Justice, the Department of Health Research, Department of Urban Affairs, Department of Public Health, they are not given that much of importance to cater around the rehabilitative services among those people who are requiring such services. For example, the transport, the roads, the accessible public transports. So we have to think about that. We have to give a more priority to such aspects. Last is that coordination, which we really lack for this. For this, in majority, most of the organization, they are not sharing their information with each other. I don't know for the best reasons known to the individual organization, but I think we must come up with a coordinated approach, sit together, and I think we are working towards Viksit Bharat, and this futuristic technologies and the coordinated approach would be one of the pillar which we will be talking about that. Now, why do we have a prioritization, and how do we do with the prioritization, and is there any method to do the prioritization? Yes, as I have said that, yes, we have a very complex pluralistic healthcare system in our country, and around 70% of the care is provided by the private health sector. And that leads to really out of pocket expenditure. We really need to understand that how this can be curtailed down and how to set a priority. And because before we make a priority, we need to identify that what are the existing policies. And this policy making in our country is led by various agencies and the various departments, and totally aligned sometimes at a central level by taking the inputs from various departments. So it is sometimes it is horizontally coming up the information from the state level, or sometimes it is just made at a central level by taking some inputs from senior officials, so, and the departments. So that is again is a not standardized structured formatting in our country, that we need to have evidence based policy. But yes, we have a tool, and that tool is the health technology assessment. That health technology assessment is the thing which has been recently initiated by Government of India, by Department of Health Research, that this is a tool which can really set the priority for our country. And if we set the priority, we need to take hold of all the stakeholders which are working in this particular domain. If we want to set the priority for diabetic health research, if we want to take the priority for cardiovascular health research, we need to have all the stakeholders on board. And as I said, that records and the data is the one things which you need to start up, and we need to have the seamless records available for having the continuity of care across the various platforms. So these are the stakeholders which will be definitely required for setting the priority. So on the right hand side, if we have to have the health technology of various devices, various domains, various guidelines, various products to be done, on the left right hand side you can see the users of the health technology, and other side the producers of the health technology. But it is not only health technology, but it is overall ambitious thing which embarked upon not only the products, it embarks upon the coming up with the guidelines, coming up with the diagnostics, coming up with the devices. So we have the national health program managers, we have the state level health program managers, we have the regulatory agencies, procurement agencies, and financial system. And below that HTAIN, we have the hubs who can generate the evidence with the help of the research partners to know that, yes, these are the priorities in our country. And we have published a paper in 2018 along with the nice UK partners, that we need to have the priority in this our country. And these are the mechanisms through which we can, make the prioritization. Now, addressing the rehabilitative services, I think everybody knows about it, our declaration, and we cannot go away with providing rehabilitative care. It's a continuum of care. It seems to be a theoretical aspect, but we really need to have the approaches which are really practical approaches. This is the conference through which we can really think about that. What are the special, things which can be delivered through an institution? What are the special such approaches which can be delivered through a community-based approach? Or what are the approaches through which we can have the outreach of the population, which are migratory, the tribal, the rural, inapproachable population? So we really need to have the different approaches through which we can, reach to the different target audience. And we really need to strengthen all these three, strategies through which we can approach, we can improve our rehabilitative services through various platforms. Coming to the ICMR initiatives, right? I think just to let the audience know that Indian Council of Medical Research is taking the extramural research program, and in there also we need to set up the priorities. And we set up our priorities depending upon that what is the need of the country. We have been dialoguing with the Ministry of Health and Family Welfare, our sister department of Health and Family Welfare, that what are your priorities, and it is we as a scientist who can debate upon that, this is the evidence, we have the so much of the disability, we have the so much of the rehabilitative services which need to be strengthened, and that is how we can put it into our call for projects also, disability and rehabilitation as one of the important area for research, and especially for the elderly care perspective. I think the recent call will be out where we have to put up some of the projects for the elderly healthcare which can identify targeting towards their rehabilitative and their special care needs aspect. So we have the four domains, and one of the domain is the delivery research, and this is the implementation research, how we can implement the policies, how we can implement the evidence of improving the rehabilitative services through a wider platform, which is the community based approach. That is the main agenda for which I have been addressing to this larger audience, that yes, we really need to have a more and more implementation researchers for the country. Just to let you know that we do not have much researchers, because the concept of implementation research is a novel concept, though old, but we are gearing up to get up the implementation science research more and more for this country, because people do not understand that what really the context is. They just try to come up with their, explaining what the problem is, how many locomotor disabilities are there, but are there any evidence which can address how to strengthen the Indian public healthcare system through a public or the private approach? Those strategies need to be implemented. So those are the things, I think we need a special workshop, we need a special planning, that how do we integrate the proven interventions in rehabilitative services into the mainstream of the public healthcare system. Another thing, I think, if some of the the dissertation topics which most of the students keep struggling, because the research part has to start from very early into the career of any researcher, academician, or a clinician. So we have the Shodh Ganga, which can really tell us that what are the different topics. If you don't find any topic on rehabilitative services improving and strengthening the health system aspect, probably you can add on, or if any research has been done on these aspects, so we can put up those areas into that Shodh Ganga list. Another is the stakeholders participation. For priority decisions, we really have the stakeholders consultations, which we really call it as a national health research priority projects. These national health research priority projects, right now we have started few projects on non-communicable diseases, and of course the disability and rehabilitation services. We do not have much projects initiated in this area. So we need to, through these conferences, the message should come to the Government of India, Ministry of Health and Family Welfare, that yes, this is the priority. We need to understand, please identify at least 10 to 15 research topics in this. All the stakeholders who are attending this event may let us know that yes, these are the approaches you need to be integrated with the Department of Health Research and Indian Council of Medical Research, so that with the next call we can put up these areas of research into the open call. Another is, it is not the researchers' priorities. So we are trying to make researchers' priority through undertaking various initiatives, like which would be shared with one of my colleagues who is attending this conference physically, that how we are making this information more and more prioritized by undertaking the national survey, which is on the really part of the WHO rapid assistive technology assessment tool. And this is one of the largest survey which we will be undertaking in 25 different sites in the country, which will really assess the impact of the rehabilitative services right now, and how many will be satisfactory scale, and how many would be, how much is the scale up which will be requiring, will be really coming up at the end of around 12 to 18 months, 12 to 16 months a survey, which will make researchers as one of the priority through undertaking this Indian Rata survey, which the results and findings would be very soon out. So my suggestions would be that yes, we really need to advocate for mainstreaming of the systems and the services by and large. Invest in specific programs and the services. We do not have crunch in financial aspects, but we really need to invest more and more money. We really need to have more and more companies to come forward and invest in various specific programs, in provisioning, in training, in making the things available. Thirdly, we need to have the capacity strengthening of the healthcare providers and the program managers to make them understand that yes, this is the need of the hour, and this is how if we add on the existing quality of life to our population, our productivity is going to be higher and higher. We need to focus on educating the disabled children, because this is none of their fault. They should not be deprived of not only providing education, but all walks of life. We need to have focus and invest more on these disabled children, and increase public awareness. It should not be labeled as a stigma. It should not be labeled as one of the aspect that okay, yes, he or she is suffering from such and such illness, but really to encourage the community engagement, community awareness that okay, they're part and part of our life. Another, generating representative community based data, which we do not have, and strengthen and support more and more research in these aspects. And these are my C approach, which I'm very fascinated about, that if we are continuous, and most of these C's are very true for Dr. Rajni, because she has been very persistent and continuous and convergent efforts that she has tried to bring all the stakeholders together. And I think this is the conference on which we have the coordinated approach, collaborative approach, convergence approach to improve and strengthen the capacity of this country so that we can communicate well, and our continuous efforts will definitely bring about some of the other cost-effective strategies to improve the rehabilitative services in India. So we need to have an appropriate, approachable, acceptable, available, and affordable rehabilitative services for our people. And I stop here, and I look forward for the comments and views from the participants. Thank you so much, and thank you once again, Dr. Rajni, for inviting me to this conference.
Thank you so much, ma'am.
Ma'am, the audience here is saying congratulations to you for delivering this talk online, because this is a very, very important strategy of research prioritization of rehabilitation science in the country, and all the suggestions that you have made and the strategies that ICMR is considering will certainly transform rehabilitation science in India. So thank you very much for this effort that you've made online, and we look forward to be a part of the ICMR rehabilitation research strategy. Thank you once again, ma'am. Thank you for your effort. Thank you. And now, before we leave for a break, here is a message from the Chairperson of the National Commission for Allied and Healthcare Professionals, Ministry of Health and Family Welfare. Unfortunately, because of some administrative emergencies, she is not able to be here, but there is a request from her to read the message as it is. So I'm going to read the message as it comes from her. I'm very delighted and would like to congratulate MGM Institute of Health Sciences for organizing the conference with the aim of mainstreaming rehabilitation in healthcare system of India. This conference is in collaboration with the WHO and with the aim to disseminate the packages of interventions for rehabilitation developed by the WHO among all healthcare professionals involved in delivering the rehabilitation services. Being a physiotherapist and holding currently the post of Chairperson of National Commission for Allied and Healthcare Professions, the regulatory body for healthcare professions, I can say that NCAHP have started functioning, and it is in the process of forming standards, regulations and registrations of healthcare professionals of India. With that process, the awareness among professionals and stakeholders has increased and will increase further. Our Honorable Prime Minister's vision and dream of heal, by India and heal in India. Under such projects, the gaps will be identified and addressed, and the process of delivering the healthcare services at primary, secondary and tertiary healthcare will be much faster. My sincere apology for not being able to join the conference due to unavoidable administrative circumstances, but thank you very much, Dr. Rajni and the entire team of MGM Institute of Health Sciences for inviting me. My best wishes for grand success of the conference. Thank you. So this was Dr. Ragna Shukla, the chairperson of the Central Allied Health Council and the principal at the Government Physiotherapy College at Ahmedabad. So with this, we now have a break.
Founder, trustee and editor at Nina Foundation, Mumbai. A 23 years old professionally managed non-profit organization for holistic result-oriented rehabilitation for people with spinal cord injuries. Her path-breaking PhD is in healthcare rehabilitation management. She has experienced a spinal cord injury while paragliding in 1995. Since then, she has been an active crusader, expanding rehabilitation services and providing it at both rural and urban setups for underprivileged survivors. She is an activist for advocating and bridging the gaps in rehabilitation for individuals with spinal cord injury across their lifespan. She is the editor of one publication, One World, just published their 36th issue. She has authored a coffee table book recently. Please join me in extending a warm welcome to Professor Ketna Mehta.
Namaste, and extremely grateful to Dr. Rajini, my dear friend, and I think whatever all the stakeholders are here for, you make me feel like a queen, because it's all meant for whom? For the consumer. And here I am going to talk to you about, like Rajini said, my own experience of spinal cord injury. Mumbai, the financial capital of India, and also through our NGO Nina Foundation, reaching out to the most underprivileged rural and urban poor friends with spinal cord injury. Yes, it can be done. I would like to make a special mention of my volunteer Saisha, who's here, who's helped me with this amazing PPT. She's a very young volunteer, so let's hear it for her. Thank you, Saisha. Thank you also to the MGM volunteers, especially Durant. Grateful to you for being my shadow throughout, because I think all these things matters when we talk about accessibility, when we talk about various things that affect spinal cord injury. So let me quickly take you through my personal experience. I have been an adventure sports enthusiast and done each and every adventure sport that you can speak of. Yes, I am also extremely academically qualified, being a university topper from the premiermost management institute of Mumbai, Jamnalal Bajaj, and being a visiting faculty when I decided to do paragliding. This was in 1995, a camp which was in Mumbai, and I said I must try my hand at this, and I did. And in terms of safety equipment, I just had that helmet. And I had a crash landing, which resulted in, it was exhilarating. And a lot of people who visited me at the hospital asked me, will you do it again? I had this big, broad smile on my face, and I said yes. So, my personal experience while doing paragliding was, in short, I was carried from the site in the tent cloth like this, which caused maybe the spine injury. I was taken to a general practitioner who already decided that will be seeing me and wasn't there, and then orthopedic surgeon Dr. Riten Pradhan, which actually changed the destiny of my life totally in terms of positive developments. So this is my rehab journey. I'm extremely grateful that I got to meet the best of the best, rescued by Dr. Riten Pradhan, gold medalist from Sion Hospital, operated by Dr. Shekhar Bhojra, the first spine surgeon of India, rehabilitated by ace physiotherapist, my guru, my father-like figure, Dr. V.C. Jacob, unfortunately up in heaven right now, but taking care of us, and my amazing family. I think in India what we have, which most of the developed countries lack, is a family support system. My sister, Dr. Neena Doshi, a homeopath doctor, taught me CIC. And that was absolute liberation. Today I asked all the physiotherapists here, are you taught how to do self-catheterization and teach other friends? They said, we are shown videos. I said, those workshops need to be held, because that's the difference between me coming out here and hundreds of my friends still living inside. My brother-in-law, Dr. Himanshu Doshi, taught me the intricacies of using my upper body for getting fit, because that was how I learned to crawl. That was how I learned to hop. The first floor of my building, I was carried up by my brother-in-law on his shoulders. Whether you're a university topper or whatever, this is the reality of living in our country. Today, I can request, even if there is a one wheelchair participant or a speaker, we have a dignified access. We have facilities, because that's the only way we can get in, you know. So we have the programs on accessibility, but it's actually getting there. So my sister also took me to all my management conferences, etc. And 5 years into my spinal cord injury, we suddenly lost her, and that's how we started Nina Foundation. Now, the personal experience was that the entire team that I was very fortunate with, we set up Nina Foundation, and they are part of the Board of Trustees. And we decided we are going to reach out to as many friends with spinal cord injury as possible. This is Narratives of Courage, Lives of Spinal Cord Injured Survivors in India. And I have got 5 copies out here. I wish you to take this back, because the reality of India and living with spinal cord injury in the remote rural areas are featured here. They are real people with real problems. This is our research finding in terms of what we actually do action research in the state of Maharashtra. Though we work pan-India, this conference being here, we are showing you this. These are all our SCI friends in each of the districts of Maharashtra, real people. And they are our friends Samruddhi, Ramesh Guge, Chagan Sonule, you know, farmers and daily wage earners. And, you know, they just don't have a clue. They don't even have an air mattress. They are operated. After that, none of the primary health care centers has a physiotherapist. They do not know that you need to sit on a cushion, otherwise they will. And unfortunately in India, most of the deaths that we have ourselves in Nina Foundation, you know, come across is because of bed sores, grade 4 bed sores. So let me just quickly tell you about some of our friends and their journeys. So this is Kiran Shekokar, lives in the small village. For almost 9 years, she lived without rehabilitation. She was on the bed, she had wounds, etc. The father said, don't worry, I'll take care of you. And after her father expired, she got in touch with a rural head, Rajeshri Patil, and then learned that I am capable of getting rehabilitated. I can work in the kitchen. I can sit on a wheelchair. And she's a youth Sai Baba Bhakt, that I can even visit temples. The basic of basics was not there. She was on an indwelling catheter. So there was no rehabilitation for 16 years. Shocking. This is right here in Mumbai. She is a recent case of ours, Mrunal Dhotre. Right in Mumbai, in Bandra, the slab fell on her head and she incurred a spinal cord injury. She is actually studying radiology. Now see the awareness, Dr. Wadhwa and all the surgeons who are here, I would like to appeal to you, that for surgery, without realizing, they took her to the best hospital and they spent over 40 lakhs. Now they don't have a single penny for rehab. The father is just a class 1 government worker. What does she do? How does she move forward? She is at All India Institute right now. They don't even have diapers. He is a gentleman whom we met in Mumbai, and Mahesh Saraf, and I am putting this in a very light-hearted fashion, that he has a bowel program which can enter the Olympics. On the side, whoever is interested, I can explain to you. Okay, so they are not even guided. How do we have a bowel program? I was very interested when, Dr. Mohammed, you mentioned about the WHO programs where there are specific guidelines for bowel programs, for bladder programs, etc. So WHO has it. What it requires it that the last mile, the friends who are spinal cord injury living in villages, they need to know how do we go about implementing it. This is a very sad case of Kranti Bhosle, who's based in Asalfa in Mumbai. So in Mumbai, you have slums which are on top of a hill. And she was on that roof and she crashed. Can you imagine, unable to move out of her house at all? Because there are steps. She needs 4 people to be carried and to be taken out. Happy to say, Nina Foundation got her out last Saturday when we celebrated our 15th Spinal Cord Injury Awareness Day, and she said that my heart is so full that I am right here along with all of you. Can you imagine? We are talking about rehabilitation. I believe the biggest rehabilitation is to be outdoors, out in nature, under the sun, being able to enjoy the fresh air. I think that is the basic, and we are talking about human rights. That human right is also lacking. This is right here. It takes an effort to, but we do home-based rehab. All those interested, we have a publication called One World, which I edit, and the latest issue is 38 pages. Those who have patience, give me your WhatsApp number, I'll send it to you. Please do read, and there are videos about how our rehab professionals reaches a home 3 times a week. He's a young boy called Kostub Banka. He got treated for tumor of the spine, injection which was part of the chemotherapy process led to spinal cord injury. So he has both. He's recovering from the ill effects of chemo, plus he has a spinal cord injury. Again, staying in Andheri East. So poor. I mean, when a poor person gets any kind of, and WHO calls spinal cord injury as the most devastating, permanent, incurable disability in the world. What is India doing about it? Are we getting to actually reaching accessibility to the ones who do not have anything? They don't have education, they don't have finance, they have no clue about how to progress in life. How do we get there? So we start with an appropriate wheelchair. I think it makes so much of difference for a child not to be sunk in a hospital chair, but to feel dignified in an appropriate wheelchair, to be able to wheel himself. And now we are trying to get him into school, because where he stays, there is this huge pipe and he's not able to get there. And there are stories and stories about Government of India giving a pension, but after so much of a struggle and intervention by us, his pension started this month. He was so happy. Even if it is 1,200 rupees, how much dollars is that? Hardly anything. It is important. Cost of catheter, the cost of urine bag, the cost of, for quadriplegics, caretakers, that is important. All right. So this is all the costs that we have: medicines, supplies, equipment, treatment and rehab. Our biggest cost is transportation to get the patient to a center. This is the cost of living with spinal cord injury in India, both paraplegia and quadriplegia. These are the gaps. Information, access to rehab, knowledge about rehab, access to appropriate assistive technology and physiotherapy. Occupation therapy, activities of daily living, unheard of. I never got occupation therapy. No insurance, no pension, no employment. I mean, you name it and we don't have it. So all these are issues, and there are 1.2 million people with spinal cord injuries. 85% are because of road traffic accidents, and believe me, India could be #1 in terms of people with spinal cord injury if the kind of data that we have. So there is lots that we can talk about. We are taxpayers. We all voted in this elections, and all of us were vaccinated. So why can't we get rehabilitation? Thank you so much.
Professor Ketna Mehta's talk, I think, sets the scene so well for our first panel of discussion, and that is gaps in rehabilitation care. She has very, very precisely and crisp laid down what are the specific gaps as a citizen of India in rehabilitation services that they should have access to. So we now begin with the first panel for today, which is gaps in rehabilitation service at primary, secondary and tertiary healthcare.
So may we invite on stage the panelists. The moderator of this session is Dr. Sai Lakshmi Ganeshan. She is the honorary professor at MGM School of Physiotherapy, Navi, Mumbai. Dr. Prakash Doke. So may we have you on stage. Dr. P.K. Lenka. Dr. Charu Sharma, Dr. Saroj Sanghvi, and Dr. Tashi Topge. Dr. Tashi is the chairperson for this session. May we request you all to come on the stage.
I was supposed to say good morning, but good afternoon to everybody. And it's been a very inspiring session since morning, and I think Dr. Ketan's talk was, I have no words for it. So basically here we are talking about the Indian healthcare system, which is a private and public sector, and dealing with a diverse and complex healthcare system to catering to about 1.4 billion inhabitants. So that's a huge, huge, complex and diverse culture that we are dealing with. And the country's healthcare regulatory system, basically managed by the private and public healthcare, is divided into, the primary, secondary and tertiary healthcare system. The primary where is the first contact where we go into. The secondary healthcare system where we seek specialized care, and the tertiary, of course, we know where we have super specialties and inpatient facilities. So this, along with the private teaching hospitals, we are trying to merge the gap. And when we talk about it, yes, there are gaps, but I think we are making the first step to identify the gaps. The key is to identify so that we can probably opt for solutions. So to discuss these gaps in rehabilitation, I think we have a very respected panel members here. So we have Dr. Prakash Doke, who's a head central research and from the Bharati Vidyapeeth Deemed University. We welcome you, sir. Dr. P.K. Lenka, who's a head of Department of P&O in the National Institute of Locomotor Disabilities. We have Dr. Charu Sharma, who's a physical rehabilitation project manager, International Committee of the Red Cross. We welcome you, ma'am. We have Dr. Saroj Sangvi, who's teacher of the teachers of the teacher, and she is also the past president and the Lions Club of Mumbai. We have, of course, Dr. Tashi Togge, who's a regional advisor for disability, injury prevention and rehab at the WHO Southeast Asia. So I may be sounding rude, but we would request everybody to, have the discussion, each one of you, to about 3 to 4 minutes, because we are very, very short of time. So the first question that I would like to ask Dr. Prakash Doke is, what is the current scenario of rehabilitation at primary healthcare level?
At the outset, let me thank the organizers, because I am very happy to speak about, I am very passionate to speak about primary health care. Since 1978, I am either practicing, teaching or shaping primary health care in Maharashtra at least. So, when we say primary health care, it reminds me of my teaching. My teacher taught me, I was teaching, the foundation of health care in India goes back to 1946, 1 year prior to independence. And at that time, and even today, we are speaking of integrated care, integrated care, integrated care. And integrated means preventive, promotive, curative. The component of rehabilitative was really missing. And as I said, not only primary health care, which the board committee's report was the foundation of total health care services. So, why they were missing? They were great persons, I respect them. But probably at that time, the need was not pursued that extensively. The average life was 37 years. Half of them, what is there? So naturally, the problems related to elderly persons, they were not there. The problems related to non-communicable diseases, they were not there. So because of this, probably they have not included it. But in 1978, the term comprehensive health care services came into existence, and there the component of rehabilitative care was added, a flavor. But it was only a flavor and not meal. So then, after this just initiation of rehabilitation services, what has happened? When we see a primary health center, in concept, primary health center never envisage specialist. Physiotherapist, I believe it's more or less physiotherapist. So it was never envisaged. What is primary health care? It starts, most is non-medical. These non-medicals are ASHA, Anganwadi workers. Paramedicals, they may be physiotherapists, technicians, optometrists, and then medical. And to me, why we are interested in primary health care? Because the government in rural area, tribal area, senior persons who are vulnerable, only public sectors thinks about them. Tribal people, rural people, women and child, and elderly persons. So there is a need. But what is being done now? Till now, is there vacuum? No, I don't say there is a vacuum. Because India was the first country to start prevention of blindness program, rehabilitation for old person, blindness because of cataract. That was the first program, I believe. Across the world, that was the first program. What next? We also started district mental health program, where a psychiatrist from districts or mental hospital was teaching to medical officers and providing regular drugs at primary health care level. More recently, in Palghar, we started what is called as RBSK. In the RBSK, disability defect prevention. Not only prevention, early treatment. But again, unfortunately, there is a long list, long queue for getting admitted. There is no manpower. This is only for treatment. Most common is congenital heart disease. As a defective disability, we don't have cardiac surgeons who are dealing with pediatrics. We have plenty for adults, but not with pediatricians. But then there is a start. We have DEIC in every district, and it is well functioning. Most recently, again, I am very proud to say that we have about 2 lakhs primary healthcare institution in India. About 1.6 sub-centers and about remaining 31,000 primary health centers. And the present government has started health and wellness center. The wellness component is introduced for the first time. And the 14 categories in wellness center include something like rehabilitation. So I think this is the greatest opportunity, madam. 2 lakhs institutions, health and wellness center. And then only one sentence I would like to say. If you want to meet the gap, there is a gap. We have another session for that. But to me, there are 4 Ds. What are these 4 Ds? First, destigmatize. And deaf person, a blind person, a leprosy patient, there is a stigma, destigmatize it. Secondly, demystify. We don't need highly qualified physiotherapists. And there is not something rocket science. So demystify it. Delegate. Madam, all this sitting person, delegate these powers and accountability to poor ashas. Poor in the sense that they are not that qualified. This is delegation. And fourth is deterioration, no. If you follow this through, I think it will be well done for senior persons, tribal persons, women and child persons. Thank you.
Thank you so much, Dr. Prakash Doke, for giving us a brief. There are gaps, yes, we have identified them, and you have put in some solutions too. So, well taken. Dr. P.K. Lenka, I would like to ask you, what is the current scenario of rehabilitation in the secondary and the tertiary healthcare centers? And how do we probably strengthen them also?
Thank you. Again, I am thankful to the organizing committee and their invitation to talk on this topic. Myself, Dr. Prasanna Lenka, I am from National Institute of Locomotor Disability, one of the apex institutions under Ministry of Social Justice and Empowerment. Since the morning, I just heard up the Ministry of Health and Family Welfare and Rehabilitation. We are the ministry, who are the nodal ministry on rehabilitation. We have around more than 269 district centers, more than 25 state centers, and we have 9 national institutes
on specific conditions or specific area as a specialization. So what I understand from this topic, the primary health care, secondary health care or tertiary, that should be connectivity, that should be a network or some kind of app or some kind of centralized database which can mobilize or which can map where the persons with disabilities are. To initiate such program, our ministry in the last year, they initiated a program called Early Intervention and Early Identification. That's a huge success. I was just going through the WHO data. We found most of the childhood disability or most of the congenital anomalies or birth defect that should be addressed as early as possible. I will give an example because limitation of time. I have been told to talk on the secondary and tertiary. So let's say district hospital. How many? We have around 746 district hospital under the health sector. Regarding the policy, I am not the right person to talk. The Ministry of Social Justice on the health subject, Ministry of the Health is on the health subject, Ministry of Social Justice on the rehabilitation subject. So that should be a multi-sectorial collaborative approach with a common objective to streamline the cause and the conditions. I know we are the nodal ministry, we implement the act, we implement the scheme, we implement the policy, but there is no connectivity between the district hospital and DDRCs. Suppose let's say 746 district hospital. Are they connected? Because everything comes from the Government of India GIA. Why not they will be connected? Persons are citizen of the India. So instead of duplicating the same service, we can connect, we can maximize the utilize, and we are the largest or main producer of the manpower, human resource. The DDRC concept basically are just major 4 things like hearing aids, speech therapy, and mobility therapy like occupational therapy or physiotherapy, and one of the major companies, assistive devices. We have different schemes, what people get free of cost, that is assistive device, scholarship, accessibility, education, skills, empowerment, recreation, and social integration. So these are the services which can be integrated to district hospital through a network. What is the solution, as you asked? Solution, what I say, advocacy first. Second is the centralized database, or we have a unique UDID platform that should be used by the both Minister of Health and Minister of Social Justice, so that same person, where he is going, how he is going, where he is, we can map together. Madam has already put the bell, otherwise I could have talked a lot. Thank you, madam.
Thank you so much, sir. Yes, as you rightly pointed out, connecting the dots between the primary, secondary, and tertiary is somewhere we need to begin. So, Dr. Charu Sharma, I would like to ask you, with the experience of working in several challenging contexts around the globe, how does the physical rehab program of the ICRC address the current gaps in rehabilitation, especially here in India?
Thank you for the question. A very warm good afternoon to everyone. So at the outside, I know the time is limited, so I would be thanking the organizing team and Dr. Rajni later probably. So coming to the question, so I would want to talk about the International Committee of the Red Cross. It is an international humanitarian organization which was established way back in 1863. So it's more than 160 years of this humanitarian organization working in over 100 countries all over. The program, Physical Rehabilitation Program, which works for providing rehabilitation services with those with physical disabilities, is active in over 40 countries. In India, we have been present for over 2 decades, and we've been working in partnership. To address these gaps, you may find me repetitive because to address the gaps, our four-pronged approach is about accessibility of services, because be it primary, secondary, or tertiary, these 4 points which I'm going to tell you, you will find it resonating with all the 3 levels of healthcare. Access to services, quality of services, and as I said, few of these points have already been spoken about previously as well. sustainability of services. Talking from international, as work experience which we have, the sustainability of the projects, not only in India, even in the other countries, we find it difficult. Why so? Because unless government takes the ownership of those projects, that's why we work in collaboration with the national institutions. And then social inclusion. I think what's been missing since morning, and I'm glad Nina was around to speak about, how the perspective of a person with disability, that needs to be incorporated. So in social inclusion, what we exactly do is wherever we support all these partners which we have, we try to include vocational training, educational programs, sports, so that they are reintegrated into the society. And now there is also fifth element, that is disability inclusion. So I would say that these gaps can be addressed better if you have person with disability. They are in your workforce, be it at primary, secondary or tertiary level of healthcare. I think many of the challenges will be able to be addressed better because they'll be part of those forums. And also one thing I wanted to mention, that it's very important that we all gather, not just once, more and more, at the same time, being less repetitive, because we know already the gaps of the dais. We've been talking about these gaps. We are from India, we know the gap, where are the challenges. So how to address and how to work in harmony. I think that is something why we are here, but we need to continue this dialogue. This is what I would want to stop at. Yes, thank you.
Thank you so much, Dr. Charu. Yes, we are talking about functioning. What is missing is participation and inclusion, which we really need to think in a forefront. Dr. Saroj Sangvi, I would like to ask you, how do you think being in a non-government organization and yes, so being in a non-government organization and working in the forefront for pain and disability, how do you think premier NGOs like Lions Club can contribute in filling the gaps in rehabilitation?
Well, I would say we can fill up the gap, for which main thing and important thing is financial support. And our Lions International, we have a Lions International Foundation. They give grant for particular projects, provided project is benefited to the society at large. But for individual person, usually they don't give any grant. So what we can do is apply for the project. And I won't say sky is the limit, but we can try for our level best. For example, 3 years ago, through our Lions Club, we have to involve local Lions Club also. So 4 years ago, we had asked for the loan, a grant rather, and for the genetic testing laboratory. And it was approved at the cost of about 45 lakhs of rupees. Partly our club contributed for that, and we got 45 lakhs, purchased 3 machines, and my aim, being a physiotherapist, is prevention of deformity, especially in child. So this was a very good project and well appreciated in our district also. So there are possibilities of getting grants from the international, provided the project is proper and they have a prescribed forms. So we have to give the details on the prescribed form, and maybe grant is granted if it is properly drafted rather. Thank you.
So thank you, ma'am. This is very interesting to know where, as a country, we definitely depend on private and public healthcare sectors. So now through you, we also know that NGOs can be approached to this, and having so many NGOs working and doing remarkable work, I mean, we have to admit that they are contributing to the betterment of the society. So this was a very great information shared by you. Thank you so much, ma'am.
So our main aim is mainly on preventive aspects like diabetes, childhood cancer. We try to help them out for the preventive aspects, more of that.
So maybe you should start promoting rehabilitation also as part of the NGO activities, because it is a need of the hour. Thank you so much, ma'am. Dr. Tashi, I would like to ask you, working with the Southeast Asia profile, so what is the rehab gap profile of Southeast Asia region? And are there any specific observations that you have done with regards to this?
Thank you very much. I think this is a very interesting question. The gaps as such, as I highlighted in the morning, there's a huge gap. The needs are huge. For example, if you take India, 410 million is a huge gap. And that translated needs of the persons with disability is also included in that. And the more important component is trying to reach to the people in need of rehab services. As we saw in the presentations of Dr. Ketna, the people in the rural areas, people in the communities, they need to get the services. Therefore, we need to reach the rehab services at the primary care center. That to be integrated within the public health sectors, within the health, and the reach the rehab services in the communities where people are dwell. So people-centered approach has to be integrated for the rehab services.
Thank you so much, Dr. Tashi. I would also request you to summarize all the speakers and probably just give your valuable opinion and suggestion.
So I think we had a rich discussion out here, although we have not much time for them to highlight so many important things. So first we learned from Dr. Prakash that through his vast experience, the history of primary health care approaches and what we need, the integrated approach of the rehab services, and through the, if you can do away with the 3 Ds, 4 Ds, destigmatization, demystify, delegation of powers. These are some of the very key components that we can really, if we can approach in this manner, that we can provide these services. And also we learned from Dr. Prakash, Dr. Lekha, right? Dr. Lekha, that at the tertiary care center, and there has to be a continuity of services from the primary health care services to the tertiary care services. Referral pathways has to be very clear. Often we learned this in the morning that rehab services are not included when not planned exactly when you are doing the surgery of spinal cord injury, and a lot of money are put in the surgery, then there's no rehab services left. So there should be a comprehensive services approach, there should be a continuity, and there should be a collaborative approaches. So that we learned from Dr. Lekha and also from Dr. Charu, that sustainability is a key component. And the ICRC, through these international approaches, has been trying to work with a lot of other NGOs, work with the government agencies, and also work with international agencies. And we work quite closely as well in improving the access, quality services, and also sustaining the services that the healthcare provides. And through Madam Dr. Saroj, from the perspective of the NGO, how that can complement or supplement the approaches that the government has taken. Often, the international bodies, the government agencies can't reach the people in need, can't take care of all the people who are in need. So that brings the chapter of the NGOs, where to fill in the gaps. They have much reach. So therefore, it's very important that we include the persons with disabilities when you're making decisions, when you're debating in the scientific community, and also making are important decisions in the healthcare approach. So therefore, at the global level, when you talk about nothing about us without us, that's a clear message that we need to include everybody, we need to collaborate for the benefit of not only persons with disabilities, not only to improve the rehab services, but as a general population, as we learned from Dr. Asher, that curved effect has benefited not only persons with disabilities, not only people in need of rehab, but over the general society. So therefore, I think this has been a rich discussion, and we learned a lot from your discussion. Thank you very much for your valuable inputs, and thank you.
Thank you so much, sir, for summarizing. I think this is just the first step. Although the time was very short for this, I'm sure we are going to have a lot of series of discussion, maybe online also, because I think we definitely need to take this forward. And starting with this, so this is just the first step to meet in person, and post this, I think we'll take up the discussion much more in detail. Thank you so much to all the panel members, and on behalf of this panel, I thank the organizing committee to give us this opportunity. Thank you so much.
Thank you so much, ma'am. I would invite Dr. Rajni Mullarputtan to felicitate Dr. Sai Lakshmi Ganeshan. I request Dr. Sai Lakshmi to felicitate Dr. Prakash Doke. May I request Dr. Sai Lakshmi ma'am to felicitate Dr. P.K. Lenka. I request Dr. Sai Lakshmi Ganeshan to felicitate Dr. Charu Sharma. May I request Dr. Sai Lakshmi to felicitate Dr. Saroj Sangvi. May I request Dr. Sai Lakshmi Ganeshan to felicitate Dr. Tashi Tobge. One panel done. Dear delegates and dignitaries, now we have reached our lunch break. Lunch will be served on the same floor itself. Please take your time to enjoy your meal and network with your fellow attendees. We will join back at 2:45. Thank you.
A very good afternoon, sir, and welcome to the session. Sir, what is the current need of the assistive technology in India, and how can we integrate the provision of the same at the primary health care centers?
Thank you. Good afternoon, everybody. I am pleased to inform you that I have been very much interested with this opportunity that the MGRM Institute of Health Sciences has given me to explore the need of PHCs and the need of the PHCs in rehabilitation field. Previously, I have given 4 points to my coordinator or the coordinator of this group. Now I am just providing two mathematical models, how the PHC need to be integrated. If you go to the logo of this project, that means PIR, it seems to be circles. And you can say that concentric circles. But if you see thoroughly, the circles are not perfect. It looks like ellipse. Ellipse means there are two axes, major axis and minor axis. But in my view, it should be in a circle, perfect circle, and it should be inscribed by a triangle. In this triangle, there are three apex. One is M, another is H, another is R. That means the triangle name is MHR. M means management, H means healthcare, and R means rehabilitation. The healthcare procedures what are being followed in the PHCs, in same pattern, the rehabilitation procedures will be followed off, and the team will be basically physiotherapist, prosthetist, orthotist, and audiologist, social workers, psychologists, like this. And there will be clinical aspects of these rehabilitation units along with the healthcare facilities. This is my one model. That means there will be concentric circles, and in the concentric circles there will be inscribed triangle, then the triangle name is MHR. And the second model is inverted funnel method. Inverted funnel method. That method is very simple, and most of the researchers that are using the inverted funnel model is the people of PHCs, they will grab, the clinicians of the PHC, they will grab the mainstream and they will filter it slowly to secondary and tertiary level. And that will help if we identify the early intervention procedures of disabilities in our rural aspects. And most of the things will be covered by our clinicians working in PHCs and the technologists working in the PHCs. And the secondary problem, which is not being addressed by the PHCs professionals, they will be shifted to secondary or tertiary units. So this model will help a lot to identify and to assess the disabled people or the Divyangjan across the country, and that will help a lot to progress this rehabilitation side by side to the health system. So this is my concern, and this is my suggestions too. So I request to the WHO panel and WHO panel working in India to kindly cooperate these things, and being the national president of Orthotic Prosthetic Association of India and one of the clinicians in the public sector, that is Northern Railway Central Hospitals. So I urge everyone to give equal opportunities to all the rehab professionals like physiotherapists and prosthetic orthotists to address their issues in concerned areas. Because suppose gait training is my own area and I have to give the gait training to the patient, those who are having prosthetic limbs or calipers. So they must be addressed by the P&O people, and they will look after these things. Then in the whole rehabilitation process will be very nice and very commutative and very beautiful model. Thank you very much.
Very good afternoon to each one, and welcome you all back after the lunch to this panel on how to integrate rehabilitation in primary health care. So we have renowned and experienced health workers from different disciplines, from different partnerships, both public as well as private here, and from different rehabilitation health professors. We have with us Dr. Gauri Nambiar Sengupta, who is a Deputy Director General of Public Health and the Director of Central Health Education Bureau at the Directorate General of Health Services, Ministry of Health and Family Welfare. As a public health specialist, she brings the expertise of health promotion and the role of health education in rehabilitation integration. Followed by her, we have Dr. Prasad Vaingankar, who is the Professor and Head of Department of Community Medicine at MGM Medical College, which is a constituent unit of MGM Institute of Health Sciences. He has been the former National Professional Officer for Emergency and Humanitarian Action, and also been a part of the polio eradication with the WHO and Government of India Partnership Program. He is the President of Maharashtra State Branch of the Indian Public Health Association and has also held several positions in the public health sector. His interest is specifically non-communicable diseases, health economics, and IT. Welcome you to this panel, sir. We have Dr. Professor A.G.K. Sinha, who is a professor of physiotherapy at Punjabi University, Patiala in Punjab. With over 3 decades of clinical experience and academic experience with vast research contribution to this field, he is also an office bearer of several professional associations, bodies, including both government and non-government. He has been the ex-dean of the medicine and faculty at Punjabi University and also been decorated by several awards by the Indian Association of Physiotherapists, and he is also the former editor of the Physiotherapy Journal of Indian Association of Physiotherapists. So, sir, thank you for accepting our invitation and welcome you on this panel. Dr. Dash, who is a master's in prosthetics and orthotics and hospital management, currently in the Transport Management Institute of Rail Transport. He has had to leave for some task, and so we have a recording from him. We have on the panel Dr. Mithu Allur, who is the founder chairperson of the Spastic Society of India, which is now called the ADAPT, Able, Disable, All People Together. She's a lady who's a pioneer in care and education of people with neuromuscular developmental disabilities and a special educator. Comes in with her expertise in pediatric neurology conditions. We have with us Dr. Rupali Roy, who's the Assistant Director General. Dr. Mithu Allur will join us online. She has a recorded talk and then she may be available for some questions, answers. We have Dr. Rupali Roy, who is the Assistant Director General in the Ministry of Health and Family Welfare. Her particular expertise is in the area of disability matter and technical matter of disability in the government sector. She's worked in NCDC, Emergency Medical Relief Division, Trauma and Burn Division, National Leprosy Eradication Program, the International Health National Program for Control of Blindness and Visual Impairment, micronutrient. So I think all the sectors that relate to, this is a long list, so she comes in with a rich expertise of the pertinent areas to rehabilitation. Welcome you, ma'am. So we begin this panel today with the first question to the chairperson of this panel, Dr. Alexandra Roche, whom we have introduced to the audience, the rehabilitation program, technical advisor at the WHO Geneva office. And the question that we have to you, Dr. Alexandra, is, can you update the audience here on what is the scenario of rehabilitation services at primary health care across the globe, from where we can learn some lessons to be able to apply this?
Thank you. Can you hear me? Okay. So thank you for this question. Also, lessons learned. Let me start a little bit with the importance of rehabilitation in primary healthcare. We have heard that in the previous session already, but actually we advise countries to prioritize rehabilitation at the primary healthcare. That does not mean, and please don't get me wrong, that rehabilitation at the other levels is not as important, because several people with complex conditions, with acute conditions, they need to have access at the highly specialized, multidisciplinary, inpatient rehabilitation settings, as well as in the general referral clinics. But rehab at primary care is so important because this is where the people have the most easiest access. And rehabilitation is nothing where you go once and then everything is okay. You need to take series of sessions, and it needs to be easy to get there. It needs to be affordable, just taking into account the transport costs. But rehabilitation at primary healthcare also has another role to play, and that wasn't discussed until now. It's also some sort of a gatekeeper position, so to identify people with rehabilitation needs, those with complex rehabilitation needs, so to refer people to secondary or tertiary care levels. And something that was also not in-depth discussed is for people who have received rehabilitation at a tertiary care level, it must not stop there. They go home, and oftentimes they need to have continued access to rehabilitation at the primary health care. So this is why the access to rehabilitation there is so important. The situation, there are similarities across all countries and differences. It's again about awareness. So do people at the primary care level know about what rehabilitation is at all? For example, if they then should refer to specialized rehabilitation settings. It's about the workforce numbers and the competencies. And workforce numbers, I think that is the main problem when countries want to start strengthening rehabilitation at the primary care. So a country in India, and I assume there is also a lack of the number of workforce, they cannot create the sufficient number within 5 years. That takes time. But on the other hand, we know it's so important. So what we learn from other countries, and for example also countries where compared to India until now there is nearly no rehabilitation. Whereas most of the time in countries who have very few rehabilitation, it's only at the tertiary care level. And some countries also now start to integrating into the primary care level, but they all face a problem: we do not have the workforce. We have a number that is working at the tertiary care level, but we do not have numbers, sufficient numbers for the primary health care settings. So one approach is, in the long term, of course, one approach is educate more staff. You need to train and educate more staff. Of course, that costs money. But in the meantime, we don't want to wait until that. One approach is to fill that gap is task-sharing approaches, which can be quite successful. So working with the existing workforce to train them in the more basic interventions that can be delivered after a shorter training, but to make sure that people have access to a minimum set of interventions. And if they need more, then they might need to be referred to a general or secondary or tertiary care level. But start with task-sharing approaches. In a country in India, I'm here since yesterday, but I'm impressed about the knowledge, about the competences, what I hear when I talk to the professions. The knowledge is there. So it's about giving training to other health workers with interventions they can deliver safely and effectively in the meantime. But at the same time, trying to increase the number of the workforce. Just in time. Thank you.
Thank you, Dr. Alexandra. And where in a country like India, where the need is huge, the need is diverse, the need is complex, and we still have to achieve this goal with limited resources, and that's where we cannot not emphasize the importance of education, health education here. So our first question goes to Dr. Gauri Nambiar. So ma'am, how do you think that health education strategies, so far we have done this for health promotion and prevention, but how do you think the education strategies for rehabilitation will help in integrating rehab services at primary health care and particularly empowering the people themselves, the patients who need rehabilitation and the caregivers? So over to you, ma'am, for your thoughts in this.
Can you hear me? Yeah. Okay. So thank you for giving me that opportunity. I guess my slide has been misplaced. So I've had the experience of leading the National Program for Healthcare of Elderly for close to 7.5 years, palliative care for around 3 years, and mental health for about 1.5 years. And now coming into the forum of health education, and if I may say so, the concept now is of health promotion. So while health education is one component encompassing only awareness generation, health promotion talks about provision of a supportive environment, building competencies of not only the patients themselves, their caregivers, and their immediate environment. So along with that, you do have reorienting the medical services or the healthcare services, and of course a policy scenario in position. So coming back to your question, with my experience of elder care, what I can tell you is that rehabilitation per se is ingrained into most of the national health programs. So if we see the life course approach, right from antenatal care to geriatric care, rehabilitation in the form of finances, in the form of infrastructure, in the form of manpower, and to a certain extent trainings is incorporated. What is lacking is sensitization of the healthcare workforce. When I say the healthcare workforce, it is right down from the ASHA to the policy makers. So the component of rehabilitation, how it is to be delivered, what are the various components of rehabilitation, and is it possible to actually have the marriage that we were talking about within two ministries? That is the Ministry of Health and Family Welfare and the Ministry of Social Justice at the grassroots level. Is it possible? Those are the mechanisms you need to see. Last point, awareness generation can never be enough. Whether it is through orientation training programs, sensitization training programs, modular training programs, or even courses delivered for various cadres and categories of healthcare professionals, non-healthcare professionals, and last but not the least, the caregiver of anybody with functional limitation.
And thank you so much, Dr. Gauri. And this syncs in very well with our motto of Padega India, Badega India. So when we talk about Padega India, we are also talking about health education for health promotion, and not only of the school-going children and the youth, but also of people who need rehabilitation services and the caregivers. So our next question now goes to Professor A.G. Sinha, who sits here and brings over an extensive experience. So what do you think, how can we integrate, or rather than saying integration, we say how can we strengthen the existing rehabilitation services which are already there at primary health care level, based on your experience in north of India?
Well, thank you, Dr. Rajni, for inviting me and putting this question. Well, if I see my whole journey, your question I would answer in three parts. Number one, when I started, what it was. Number two, now why, what it is. And what I feel, third, that should be done, about this mainstreaming things. So when I started my career as a physiotherapist, there was lack of human resources. And there was lack of awareness and all kind of situation throughout the country, which we had just here, that spinal cord, lady has spoken about. What has changed in all these years? If you talk about the real change, India is it is a mosaic country. So we can see all phases of rehabilitation care in the country. We have areas where we have no access of any rehab services. We have areas where we have a complete high standard, world-class rehabilitation centers. We have an area like I come from Jharkhand. It is the poorest state of the country. I work in Punjab, which is the richest state of the India. In terms of rehabilitation services, the manpower infrastructure, I would say comparable. In Punjab, we don't have occupational therapy. We don't have this vocational counselor or selling, but Punjab is very good at the visual rehabilitation. Rehabilitation of visually handicapped. So we can see all patterns. So to put a thing, one shoe fits all, it will not do good. And to brand India as saying nothing is possible. I mean, you can go and see one part of the country and you can say, no, nothing is available. It is true for that area. But then the moment you come to the another area, the situation is different. This is the existing scenario. Now, what has changed? There are many things which has changed and silently has changed. I would refer to 2 or 3 program of Government of India. Like one program is Sarva Shiksha Abhiyan. Now that program, education for all, universal education program, that program has nothing to do with health or rehabilitation. But that program has done so much for the children with disability, because now it becomes mandatory on the part of school to bring all the children to this school. So all the corrective surgeries, all the physiotherapy, all the nutrition, all these services they have integrated. In Punjab I have seen, with this Sarva Shiksha Abhiyan, so many people came into the government forces. Now what need to change? I mean, how to integrate? The only thing I would say, the WHO definition of health, health is not the absence of disease. So the moment we stop looking the health through the prism of disease, the service will be integrated. So right now in India, to my mind, it is not a question of integration into primary health care, but how to integrate rehabilitation into health care. The moment we start considering the need of a patient, like I often pose a question. Sorry, I will take 1 more minute. I often pose a question. You have a fever, irrespective of any cause, you take a paracetamol, it is treatment. I have a stiff hand and I am prescribed some of the exercises, it is rehabilitation. Now both, rehabilitation is tertiary things. So where is the tertiary in that? You take, diabetic medicine to maintain the blood sugar level, and it is treatment. And when I prescribe a crutch or amputation, to manage, the same permanent loss of it, it is rehabilitation. So the question is the changing the mindset. The moment we start giving focus to the need of the people, it could be anything. So this is how I visualize. And India has changed a lot. Digital revolution, awareness is not a question. People can go anywhere. Thank you very much.
Thank you so much. So Dr. Sinha has also emphasized on awareness and redefinitions to be able to emphasize. So the next question now is to Dr. Prasad Vaingankar. Typically in most Indian health university settings or university teaching hospitals who do reach out to the primary healthcare needs of rehabilitation, the model is that the rehabilitation services piggyback on the preventive and community medicine services which have been operational since a long time. So when we are piggybacking on this particular preventive and social medicine, so how do you see that this strategy can help to strengthen the existing services at primary healthcare?
There are around 700 medical colleges all over India, and each medical college has got Department of Community Medicine, previously known as Preventive and Social Medicine. And as per the National Medical Council norms, each medical is supposed to have the Rural Health Training Center and then the Urban Health Training Center, which is looked after by the Community Medicine Department. So most of the Rural Health Training Centers, they are attached to a primary health center in most of the colleges. And that's how we provide the services, we do the research, and then we do the training of the students in that field practice area. Now, it is true that rehabilitation has been integrated with the primary health care and all that. That is at the policy level. When it comes to the field, the situation is not exactly the same. I mean, there are some gaps there already. Urban areas, yes, I mean, there is a awareness and all that. But then when it comes to the rural areas and all, what we notice is that population there for them that low back pain or the osteoarthritis is just a part and parcel of life. I mean, it just happens with the age. And the healthcare seeking behavior, if we see, then it is not markedly much improved for the elements related for the rehabilitation. I mean, as WHO has given almost 20 conditions across the 7 domains that need to be focused on for the rehabilitation. And then the functioning at the Rural Health Training Center is mostly focused on the maternal and child health since ages. And then in recent years, non-communicable diseases also have been introduced. But I would just give my experience is that what we did in our center to create a behavior change, we introduced exercises during the pregnancy in our antenatal clinic. So with the help of the physiotherapy department. So once that is established, even the mother-in-laws of those ladies, they started asking that are there any solutions like that for any physical ailments or anything for which you can do something. So the physiotherapy department, they did conduct a survey regarding the low back pain and then the spinal issues and all that, and that is how the awareness was created, and then some people could receive some help into the process. But what matters is that we need to take a proactive efforts to establish the rehabilitation integrating with the primary health care and through the medical educations in the primary health center or the rural health training center as well as in the urban health training centers. One more advantage of that is that all these activities, the medical students or the health professionals, they get trained in the process, and then those values are inculcated, or that importance of the rehabilitation is very much highlighted. Okay, it's difficult for the politicians and the public health person to stop talking, then, but at least public health people will talk what they know. So I will just take 1 or 2 more minutes. There is another concept, flagship program of the National Medical Council is a family adoption program. And this could be also a good opportunity because where the student adopts the family for the 3 years. So if it can be incorporated into the guidelines that apart from the maternal child health care or the non-communicable diseases, even these needs of the rehabilitations, if they're identified in one of the visits, or one of the visit can be dedicated entirely for that. They're supposed to do around 20-25 visits in the period of 3 years. So then also the health professionals, they will develop that attitude to or develop that sensitivity of the importance of the rehabilitation needs of the population.
I think that would be a very effective strategy of integrating rehabilitation there in the family adoption program.
Yes. One more thing I would like to say is that on the lighter note, that when I ask it to the medical students that who looks after the primary health center, most of the times the answer is ASHA. ASHA is at the lowest rank, I mean, is the medical officer of the primary health center. What happens is that when the programs are implemented, everything gets piggybacked on the ASHA. And ASHA obviously is a very successful program, and then what they work is tremendously appreciable. But there has to be some accountability of the other people in the setup needs to be maintained, and the more important should be given to the medical officers' involvement so that the rehabilitation care will get integrated along with the primary health care. Thank you.
Absolutely. Thank you. Thank you for this. And now coming to Dr. Rupali Roy, you've heard, I think we all have heard, that there are several health policies and health programs which are already operational within the country. It's all about where do we find the appropriate spaces in there to strengthen the rehabilitation services. So what would be your ideas of what is already existing where rehabilitation can be strengthened?
Yes, ma'am. When I saw the agenda here, and I have seen my topic for invited speech and the topic for panel discussion, I thought both are similar. Still, I would love to say, because as my previous panelist already mentioned, awareness generation is one of the important factor. And for this awareness generation, if the same thing I have to say repeatedly, I have to say in all platforms, so that everybody realize that, and maybe in one day we will be success. So everybody is saying we have to need to generate the awareness among healthcare providers, even among the community people. But as we are working in the ministry, I know the first step of awareness generation required among our bureaucrats and policy makers. That is the really very challenging, because as Dr. Gauri also said, and everybody knows, in all the health programs, there are component is there. But because they don't understand the weightage of the importance of this component, and they are not sensitized enough. Maybe that is failure from our side. We are not able to make them aware. So that is one important aspect, because they also be our focal point, so that we can inform them about the importance of this topic. And like for example, as I said in the morning, Ministry of Health are taking lots of initiative. It's not like that we are not proceeding in that direction. And for improving the accessibility, even in the ministry also, for the blind people, we have a tactile pavement. But right now also, if you visit to our ministry, we'll say in most of the pavement is occupied by the car. The car are parked over the pavement. So that means, because we are not aware about the fact why this tactile pavement is there in the all health infrastructure, or in the health office, or any offices. So, and that was the reason we are not like implying the knowledge, and then maybe being in the health ministry staff also, we are not able to sensitize our own staff. So as I mentioned in the morning also, this is already part, not for in health policy, which was first initiated in 1983, even in the 5-year plan, when 1951, in that 5-year plan also, rehabilitation was one of the component. And the oldest national health program is the leprosy eradication program. So in that program, which was implemented in 1953, that from that time, rehabilitation is one of the component. So now this is the time, and this is the right forum. Like after the 2 days conference, I would like to request you, ma'am, and the team who are pointing out, noting the points of all discussion, we have to come out with some specific component, and tasks shall be given to Ministry of Health, Ministry of Social Justice, NGOs, medical college. Specifically, you have to do this work. Then only maybe we have some achievement, maybe after certain years. So that is expected after this conference. And thank you, ma'am, for organizing this, and wishing you a great success, and wishing many more conferences in the same topic in coming years. Thank you, ma'am.
Thank you so much. So we're coming back to awareness, sensitization of even policymakers, because particularly when we say that the health and wellness program is up there running at primary health care, every sub-center now has a health and wellness clinic. So now bringing in what are the competencies that need to be present there to address, at the same time taking into account that task sharing is something that we need to do wherever the resources are limited. Now, while we talk about all of this, there is also an element of technology where India is spearheading hugely, particularly mobile-based technology, and the government is emphasizing a lot on digital health solutions, and that's where there are experiences from different parts of the country as to how mobile health technology can help. This is one very brief example of how mobile health technology can help, of early detection, rehabilitation, and monitoring of infants and children with neuromotor disorders. So this is a project which is funded by the state of Maharashtra, Rajiv Gandhi Science and Technology Commission. And so far we've been able to train the ASHA workers to be able to bring them and also empower the mothers and the caregivers of neonates and infants with neuromotor disability. So we are talking about bringing in technology as well as a tool that can be used in order to train the ASHA workers and empower the women. So that was just a very, very brief so far where we've reached, but I'm sure there are many such activities which are going on amongst the healthcare professions across here, the audience. So I think with this, we would request Dr. Alexandra to summarize the discussion, and we have some points which would emerge as recommendations of the panel to the several ministries who have been very supportive. So over to you, Dr.
Yeah, Rajani, actually you have already summarized the main points made. But what I heard the most often was awareness raising. So it seems there needs to be much, much more about what rehabilitation is and what the benefits of rehabilitation are. And not only among the health workers, but also among the policy makers, the decision makers. So continue with awareness raising to strengthen rehab at the primary care. Sensitization of health workers about rehabilitation, so to identify the needs for rehabilitation. That was also mentioned. I think that is one very important area where the primary health care, which is the first access usually, this is really the point to identify the rehabilitation needs. What I also heard, it seems rehabilitation is in the programs on the paper. I hope I didn't understand it wrong, but it seems it's not successfully, 100% successfully translated into practice. So that really the rehabilitation at primary healthcare is available for all. It seems there are differences across India, which is not surprising according to the size of India, and it would require also approaches that fit the needs of the specific areas to really meet the needs in the areas, not to develop something that will not fit all. And yes, again, you already mentioned the last point, next tasks, to work about what needs to be done, what kind of tasks can be done to work on 5 years programs so that they are successfully implemented. Thank you.
Thank you so much. And with this, we thank all the speakers, all the panelists on here. And may I take this opportunity to felicitate the speakers.
May I request Dr. Uttara Deshmukh, co-convener of this conference, to felicitate Dr. Rajni Mullarapatan. Ma'am.
Just wait for a minute.
May I request Dr. Uttara Deshmukh to felicitate Dr. Gauri Sen Gupta. Thank you, ma'am. May I request Dr. Rajni Mullarapatan to felicitate Dr. Prasad Vayangankar. May I request Dr. Rajni Mullarapatan to felicitate Professor Dr. A.G. Sinha. May I request Dr. Rajni Mullarapatan to felicitate Dr. Rupali Roy. May I request Dr. Rajni Mularapatan to felicitate Dr. Alexandra Roche.
Sponsors, gold sponsors, Motorica India Private Limited, SBI and IDBI for sponsoring the conference. The gold sponsorship is given by Motorica India Private Limited. Thank you. Thanks a lot.
Is the next panel. The next panel, the chairperson is Dr. Shashank Dalvi, Professor, Vice Chancellor at MGM Institute of Health Sciences. The moderator of the panel will be Dr. Savita Ravindran, Principal and Dean at Ramaiah College of Physiotherapy. Professor Sanjay Wadhwa, Professor and Head, Department of Physical Medicine and Rehabilitation. Dr. Ritu Ghosh, Academic and Technical Director, Mobility India. Dr. Shobin Saha, Associate Professor, Department of Occupational Therapy, Manipal Academy of Higher Education. Dr. Professor Prakash Bhuminathan, President, Indian Speech Language and Hearing Association. Mrs. Vaishali Sathe, Clinical Psychologist, Tata Institute of Fundamental Research, Mumbai.
Good afternoon, everybody. Moving out from looking at how do we integrate rehabilitation within the healthcare system, be it the primary or the tertiary care setup, we're trying to understand where is capacity building within the healthcare system in the domain of the different areas or the different facets of rehabilitation, and what is an appropriate time that we introduce the in-building for the incoming young professionals who are coming into the profession. What is existing right now? What would be more appropriate for us to build capacity right from an undergraduate program? Should it be something later? So we'll have very eminent panelists who are here with us, and we'd like to seek their suggestions, their views before we move on. I'd like to introduce the panelists before we begin. We, of course, have Dr. Shashank Dalvi, who is the Vice Chancellor of the MGM IHS, and so needs no introduction. He's been with us since morning, and he's been the Vice Chancellor for his second term now with the MGM IHS, and known him for a long time, and you can't, the moment you meet him, one of the other things, other than all his other attributes, he has the smile on his face all the time, all the time. And that really holds him out too much, because some of us do show our displeasure very easily sometimes on our expressions, but he doesn't. So that's how he carries the team forward with him. Welcome, sir, today to this, for chairing this session. We have with us Dr. Sanjay Wadhwa. Good evening, sir. And sir is the professor and head of the Department of Physical Medicine and Rehab at the All India Institute of Medical Sciences, Delhi. He comes with a body of clinical as well as academic experience. He has a domain of practice in multiple areas, has a lot of research to his credit, and has been part of many policy making and policy decisions from the Government of India. Welcome, sir, to this panel. We have Ritu Ghosh with us. Ritu is the academic and the technical director for Mobility India, Bangalore, India. She's the P&O expert for the Rehab Council of India for over 20 years. She runs a very strong undergraduate and a master's program in prosthetics and orthotics at Bangalore, has been on many policy activities with the central government and the state government. Welcome, Ritu, to this panel discussion. We then have with us Dr. Shobin Saha, and Shobin is an associate professor at the Department of Occupational Therapy. Manipal College of Health Sciences. He has more than 25 years experience, both academic and clinical. He has a lot of number of publications to his credit. He's active in research and in academia and clinical. Welcome to the panel, Sohan. We also have Dr. Prakash Bhuminathan, who is the professor and principal of the Sri Ramachandra Faculty of Audiology and Speech Language Pathology. He's a senior consultant at their medical center, and he's, which is obviously affiliated to the Ramchandra Institute of Higher Education, Chennai. He has more than 25 years experience, over 80 publications, a lot of book chapters to his credit, and he has a lot of awards and recognitions. Welcome, Prakash, to this panel. And we also have with us Dr. Vaishali Sathe, who is a clinical psychologist, has over 18 years of working experience in counseling more than 15,000 patients. She's worked as a clinical psychologist at the Center for Excellence for HIV Care. She's also a resource person on many projects for counseling for HIV and the AIDS counseling group. And she's currently associated with TIFR and HBCSC as a counselor, as well as the Mumbai Police. Welcome to this panel, ma'am. I'm going to open this panel discussion by taking some suggestions, some ideas, some thoughts from our chairperson, Dr. Shashank. Looking at the title of this is Weaving the Pathways of Integrating the WHO package of rehabilitation into the curriculum. Where, how, and should we do it, or is it already existing?
Now, looking at the present curriculum of the healthcare delivery system, where the preventive is one component, the curative is the other component, the rehabilitative is the another component. And weightage given into the healthcare curriculum, take medicine discipline or any allied branch discipline. Looking at these three components, the majority portion is occupied with the curative component. The preventive is also there and the rehabilitative is also there. But looking at the need, right, since the morning we are discussing, all the dignitaries have also mentioned from the WHO delegates that the rehabilitative components need to be stressed because the life expectancy has increased, the geriatric population has increased, the more and more stress now it is needed for giving socially and economically productive life to each and every individual. Rehabilitative component need to be stressed. And if rehabilitative component need to be stressed, the starting should be right from curriculum. Because if in the curriculum of all, this rehabilitative component is increased, naturally its need that will be there. And there are eminent panelists and which will give us the various pathways and then later on we will summarize, please.
Thank you, sir. I take my first question to Dr. Sanjay. Dr. Sanjay, in your opinion, in your view, how do you think we could integrate the PIR into the rehabilitation program? And how could it be built into the curriculum, keeping the fact that the regulatory bodies will then have to come in also to ratify what is there?
It is a challenge, just like integrating any new concept or practice into the curriculum. So instead of integrating it first and then sensitizing the regulatory bodies, which in case of medical education is the National Medical Commission, if we first approach NMC that these are the significant changes that have taken place in recent years as far as the education and training related to rehabilitation professionals is concerned, and we have reviewed the existing curriculum, what is the knowledge component, what is the skill component, and we are proposing a revision into this in line with the recent trends at the global level, which should reflect at the national level also. They may be perhaps a little more receptive Because it is not often that the curriculum which is existing is revised. It takes 5 to 7 years to set the process in motion, and by then the office bearers in the statutory bodies change, and many things are forgotten. There are other things also that we have to appreciate what is existing in the present day curricula and try to strengthen that. There is a lot that has happened in the last couple of decades, especially since the 1981 when the International Year of Persons with Disabilities was observed. And that set in motion many new things, new changes, programs. The another momentum was gained when 1995 Persons with Disabilities Act was enacted. This was the first major legislation. And more recently, the 2016 Rights of Persons with Disabilities Act. So these are landmark events in the history of India, which have had significant impact on the training of manpower, which is active in the rehabilitation field. So there are many things we need to highlight that, what are the positives of that. But what happens is that I don't feel happy when I say that we suffer from Ghazni syndrome. We remember a few things for short term and then forget it. Unless somebody shakes us up and then we wake up and then try to appreciate that. If we look at our way of working in the last couple of years, rehabilitation was emphasized during the COVID-19 pandemic also. It helped a large number of persons who acquired COVID-19, whether during the acute stage or chronic long effects of that. But now nobody talks of that. It is not that all the persons who contracted COVID-19 have been cured. They are still carrying on with the residual effects, and nobody is talking about the role of rehabilitation professionals in taking care of that set of persons. Then the pool of persons in need of rehabilitation, as sir in his presentation mentioned, it is not just persons with disabilities who need rehabilitation services. A whole set of persons, right from pediatric to the late geriatric age group. Injuries, non-communicable disease, sequelae and all. Those all. So we need to integrate. Integration is not easy, but it has to be reflected in the national policy and the programs which flow out of the national policy. I am very glad to share in the National Policy Document of India 2017, there are 6 places where rehabilitation is mentioned, but we have not exploited that mention. Thank you. I'll add if there is any other question.
We will get back to you again, Dr. Sanjay. So I'd like to move to Dr. Ritu. When we look at the curriculum for the prosthetic and orthotic program, how, where, and at what level do you think that the PIR would need to be incorporated, or would you say that to a large extent it's already there right now?
Thank you, Dr. Savita, for the question. So basically, I will try to answer in few components. One is that my personal experience, when I say it's an institutional experience of implementing other WHO tool, that how we integrated into the prosthetic orthotic curriculum. So I think that would help with our good practices, what we have done with the Rehabilitation Council of India. And then I will give my views that what could be the short-term functional strategies and the long-term strategies to integrate. So basically, there were 2 tools which was mentioned by Dr. Alexandra, and it was with Dr. Tashi. It was on TAP tool, training in assistive product, and another was which was not there. It was on WHO wheelchair guidelines and its training packages. So basically, in 2006, WHO came up with the wheelchair service guidelines, which has given the service delivery guidelines as well as the service delivery training delivery guidelines, including the packages, because it was not available whether it's a developing country or a developed country. They did not have the structured package. So basically what I understood that from the WHO, I think in the morning there was a speaker, they talked about champions. I think maybe, sir, I think you mentioned about the champions. So there were some global champions were prepared, there were regional champions were prepared, there were national champions were prepared, and the national champions were engaged to prepare the local champions. So we needed a group of champions to see that how those guidelines and the training tools would be implemented. Now, as I have been involved with Rehabilitation Council of India, so we had the opportunity when the training curriculum gets revision, as Sir said, Vada Sir said, it is between 5 to 7 years. So in 2010, the RCI curriculum were getting updated of the UG curriculum, and I had the opportunity because I was there as an expert member, we added it. But just addition does not complete, because it is that who will train, whether the faculty members are aware of those tools and how to implement those tools, how to use those training packages. So definitely there were a lot of training program as a CPD program, continuous professional development program, as a part of a faculty development program, as a CRE program were conducted throughout the country by us, also those champions who were trained. So this is how it rolled out. Like giving example that the WHO tool had how to train. Somebody said in the forum today that what about not only the clinician level, but at the, I'll just take one more minute, not only at the clinician level, but the implemented levels, policy makers need to be sensitized. So I think that tool was developed in the wheelchair where the stakeholders and managers or implement or directors level were trained. So I think this is something which we need to look at it. Now very quickly on the short-term functional strategy, as I've already said, the faculty development program and those needs to be done. And in the recent experience, RCI is reviewing its MPO and UG curriculum presently. So as said, the syndrome, Gajani syndrome. So though I was a part of this PIR in recommending WHO that who should be the reviewer and being a working group, I also forgot. So this, when I was contacted by Dr. Utra and Rajni about this, and I said, oh gosh, we did not include. And immediately, we circulated the information that this needs to be included, and already the exercise were done. So how could we include in a very short span? One was that we added as, we reviewed very quickly whether those health conditions are added, which is relevant. And secondly, as a reference material. So that is something which, and of course, another stage when it gets approved and when it really gets, curriculum will be implemented, then we will know how to do it. So, so that's how it's already the status that BPO and MPO curriculum has this PIR component in it already. And then in terms of, I know I'm aware of the time, so I'll just quickly go for the long-term strategy. I think I agree with Sir that we need to really review the curriculum presently, not only the PNO, other curriculums, do a kind of a situation analysis of our present workforce, what kind of competencies they need to have, where from the tertiary level to the primary level, the workforce competencies are required. I think this is something we need to do, this exercise, and basically assess their roles and responsibility. And once in 2 years, I think we need to have some kind of a forum, maybe as a national educators meet, like how we are here from different. So national educators meet and share our good practices from a different discipline. And I think that will give a very good stage of a learning platform, that how each of us are implementing. And I think with this, thank you. Sorry to take more time.
Thank you, Ritu. I'm going to go over to Prakash for two aspects that we'd like you to share your views on. Number one, the PIR has a component for speech language pathology. So where would the PIR fit into the learning? From morning, there have been a number of speakers who have said probably there's a lack of evidence in public domain within the rehabilitation activities that are happening, and that probably needs to be more out there for people to understand. So if you had to integrate PIR into academic research programs, where would that begin?
Thank you. I bring greetings from Indian Speech and Hearing Association. I'm president of the association. To the learned audience, you've been patiently listening through the entire day. Um, so, the curricular aspects, where do we fit in the PIR? So, audiology and speech language pathology profession also is governed by Rehabilitation Council of India. So, there is a regulatory body. The advantage has been, there has been a uniform curriculum across the country. So there are around 70 odd training programs from who are recognized by Rehabilitation Council. And from these training programs, around 1,500 graduates come every year. And so they all have the same level of inputs because the curriculum is fixed. Where there is no regulation, then there is a problem there. So the good thing is we have a regulation. But the problem is how frequently these regulatory body influence a change in the curriculum. In that also, thanks to our expert committee in RCI, we've been having quite periodic revisions, and the latest revision happened last year, but not yet implemented. And that revision was called for primarily to incorporate RPWD Act into the curriculum, National Credit Framework of the UGC, and the NEP of NEP 2020. So the entire exercise was done to incorporate these three aspects into the curriculum so that the next generation of speech language pathologists and audiologists will be in line with the national agenda. That was the idea. So a suggestion from this forum to RCI to include also this PIR will be the first step, I think. Once you start writing to them, and impressing on the expert committee that this has to be sort of a mandate. There was one talk in the morning which said mandates are important, and if this mandate is suggested, then possibly that can happen. The second suggestion I have is all the higher education institutes have to go through these accreditation, NAC. So if there is any way that we can impress on NAC on aspects related to rehabilitation in curriculum across disciplines. It could be skill-based education, it could be electives offered, interdisciplinary electives can be offered, and with an NEP coming in there, a lot of transdisciplinary learning is possible across the discipline, leave alone our own specialties of rehabilitation specialists who are training. Other specialists also can get an idea of these. So skill-based education, skill-based programs can come, and internship, compulsory internship is there in audiology and speech language pathology. And I think internship is a year where we can sort of have this into the, and this PIR document is pretty interesting to look at developing competencies for specific disciplines. So this can be used as a base for us to set competencies, and the competencies can be, competency-based curriculums can be developed. So that is another way which we can integrate the curriculum into this. The second question I have not answered, but that is related to research. How do we get into research? Postgraduate programs but necessarily have to have dissertations. There is dissertation in that, and PhD programs are also there. So if there is linking of these PIR into the postgraduate curriculum, where translational research, particularly looking at how cultural and language-based variations are required to implement these PIR. Speech language pathology, when we need to develop assessment tools, we need to have tools developed for different languages across India. So these things can be implemented. And quality of life measures can be focused on. So the qualitative researches, again, usually research is looked at more quantitative. Qualitative researches, if they start focusing on, PIR can be implemented there. Thank you.
My next question goes out to Shoan. Again, the first component is going to be quite similar to the rest of us, saying, how would you integrate the PIR with reference to occupational therapy curriculum? Where does it fit? How does it move forward? And could you throw some light on how would you integrate that into clinical training? Because that's also part of academia.
Yeah, thank you, madam. So there are two components of this question. One is how do you integrate into the clinical training, and the other one is integrate in the curriculum. Now, as far as the curriculum is concerned, as I went through this document, first and foremost, if you see the foreword given by the Director General of WHO, and if you read between the lines, there is an intense philosophy of PIR that is there, that is reflecting in that particular chapter. So students need to be enlightened about the philosophy of PIR. It is not the technicalities of PIR, because PIR, the components of it, they are already embedded into our curriculum. The under different heads, PIR terminology may not be reflecting. So, but first and foremost, it is the philosophy that needs to be ingrained amongst the younger generation of professionals. That is the first and foremost. As of now, PIR is a set of information. Now that needs to be broken down, because when we deliver it as a as a chapter, as a training program, both in the classroom and in the clinical training program, they need to be described. And they all have to be very, very objective. Because here I would want to divulge a little bit. From morning we have been hearing of why rehabilitation gets a stepmotherly treatment as compared to a typical medical care. Okay, one of the reasons being that there is no objective outcome. When I say objective outcome means it is in terms of time. Okay, so morning there was a definition given by Dr. Alexandra about the rehabilitation. If we can incorporate the word optimum time frame, everything optimized, optimum time frame, then we probably will be able to sell rehabilitation much better. And when I talk about selling it, because we have to sell this to the students. We are framing curriculum. What about they don't like it? So for them to appeal, there has to be components ingrained into the curriculum which is attractive, which is more accountable. Now, so as an undergraduate program, it can be the philosophy of PIR that can be incorporated. And although different components of PIRs are spread over. Now, as an occupational therapy curriculum, there are elements which are spread over 4 years of academics. So probably the philosophy can be a chapter. Okay? And then in the masters, it can be more integrated into their research, as Dr. Prakash said, it can be integrated into their research-related activities. Okay? Yeah, thank you.
Thank you, Saha. Vaishali, where do you think that you would be able to build this within the domain of the actual clinical practice of counseling from the PIR components of psychology? And if this needs to be spread or sent over, capacity building will be required at working professionals or even those who are in academia?
Thank you, ma'am, for this question. Just to give a brief definition, I was working with an HIV program, which was a national-based program. So there, what I learned, and I think what we need to understand here, if we have this integrated program, okay, psychology is one of the major component today in any section, may it be medical, may it be rehab. Psychology is one of the main component. So if you can bring that mental health program into this rehab as a core subject, and if you can train that next generation trainers, that will help. Because what I see practically, ma'am, I'm also doing I'm giving my services to other segments also, voluntary also. So where I have been seeing these patients that the patient is suffering from cerebral palsy or the patient is geriatric, he may be having all the facilities, like he may be having money enough, everything is there, but he does not get an emotional support. And why that emotional support is not there? Because no one is there at home. So if the students, like what my point here is that if you can sensitize the students at UG level only, it will be much better. And they should understand that rehab is also a part of a medical treatment. So what sir was saying, that why students or why people don't look rehab as like they give weightage to the medical, that is all because somewhere down the line, I feel that the doctor status makes them, that is what my personal feeling is, that students coming from a medical background gets a different platforms, or they have different status, to be honest with you all. And in this program, if you can integrate a peer concept, like madam you were discussing, in HIV care we have this peer counseling concept. So if you can have that module here, it will definitely help them. So I would suggest that in UG level, if you can introduce this, and also on PG level, let the students who are into the, now those who have passed out with MBBS or whatever degrees, let them get some research, but the platform should be available. So I think if you can, like MGM Institute, if you can become a nodal agency for training trainers, and if you can start some UG and PG programs, that will help a lot, because we are in a place where we are connected to the city, the urban also, rural also. So I think you should inculcate that into your curriculum. And in OPDs, I think if you start a OPD like a HIV OPD, where the patient without counseling, he wouldn't leave that OPD. So if you have one psychologist in your rehab OPDs, it will make a great difference to that patient. Trust me, it does. Because patients don't disclose so many problems with their spouse also for XY reasons, but the minute when they speak to the professionals, it'll make a vast difference. So thank you very much.
Vaishali. Coming towards the end of this panel discussion, 2 points that come out as thoughts. Number one, sitting here as a physical therapist, so I suppose looking at our curriculums, there is already a certain component of rehabilitation that comes in right at the undergraduate program, because when you graduate with an undergraduate degree, your ability to practicing is already is there with you. And however, expanded versions of it and a deeper knowledge of reasoning and beyond probably is there at the master's level. I think if you're looking at all of us on this platform, we are all a jigsaw puzzle, which pieces of the rehabilitation team sitting here. For me, I think the first thing is we need to come together to work with the patient at the center. The rest of the things will then fall into place. And that is a beginning point, because sometimes, let's accept it, some of us all work in silos. And then you're expecting that the patient outcomes should be what you're looking for. And unless we all do capacity building on teamwork, I think that's the first starting point. Curriculums will happen, regulatory bodies will come, we are here, so we need to begin here. Yeah.
Thank you, madam.
For the concluding remarks to my chairman.
Looking at views of all the panelists and also the moderator, and since morning, whatever the discussion that is going on, already WHO have prepared the exhaustive guidelines that particularly has come up into that, particularly 15 conditions, those have been identified, and the rehabilitation component and bringing it into the mainstream. And now the role of curriculum into that. And as the curriculum comes here in India, curriculum governed by the central councils, the 3 councils will come into the picture: National Medical Commission, Allied Health Council, recently come, Ministry of Health, Family Welfare, and RCI. all these will come into the picture, and they will have to revise the curriculum or enforce the curriculum, and the universities not only the curriculum inclusion, but also that should be the part of assessment, so a student will imbibe that in a more better fashion if that is also become the part of assessment. As such, routine for refresher training program, also the madam have raised the point, MMC as well as other councils are having credit points, and every 5 years such continuing medical education program for all the councils, those are being taken. So that this should be the one particular module or part, one day workshop on the rehabilitation component only, and the stress, and that should be the mandatory part of further continuation. In the faculty development program also that can be included. That can be the recommendations of this particular conference to the all councils and to the government of India. That will be better. Thank you very much. Thank you.
Hello. Thank you so much. Now I would request Dr. Savita Ravindran to felicitate Honorable Vice Chancellor, Professor Dr. Shashank Dalvi. Felicitate हो गया. Felicitation का.
Yeah, of course.
May I request Dr. Bela Agarwal to felicitate Dr. Savita Ravindran. May I request Professor Savita Ravindran to felicitate Professor Sanjay Wadhwa. I request Madam Savita Ravindran to felicitate Dr. Ritu Ghosh. May I request Dr. Savita Ravindran to felicitate Dr. Shovan Shaha. May I request Dr. Savita Ravindran to felicitate Professor Prakash Bhuminathan. May I request Mrs. Vaishali Sathe.
Thank you very much. Shooting of the timeline. So the fourth panel for today, that's budgeting rehab, will be taken tomorrow morning. So we'll have an early day tomorrow. But now we are proceeding towards the venue of the center.
A very good evening to each one of you and welcome to the MGM Center of Human Movement Science. This center is established by the MGM School of Physiotherapy with support from International Society of Biomechanics and the Biomedical and Engineering Technology Incubation Center at IIT Bombay. We pay tribute to Professor Robert Van Dusen, who has been the professor of rehabilitation science and the founder of Research Center for Clinical Kinesiology at Cardiff University in the UK. I was privileged to be his PhD scholar in 2002. He has been hugely instrumental in supporting establishment of this center here at MGM Institute of Health Sciences. And today, we have had a long day, and as we said right since morning that we are going to keep moving. So we will continue the activities here with the Center of Human Movement Science taking this occasion of mainstreaming rehabilitation into healthcare. So how does this connect to mainstreaming rehabilitation? So before we go there, these are just some glimpses from the center, and the center was inaugurated by Dr. Anil Kakodkar, who's the chairman of the Nuclear Energy Commission Mission in India. Needs no introduction, the former chairman of Bhabha Atomic Research Center and the chairman of the Board of Governors of IITs in India. The reason to mention this specifically is that this man had the vision to support the vision of movement science here in the country, particularly because movement science is biomechanics. And he strongly believed with us that there has to be a marriage between bio and mechanics to be able to apply therapeutically movement solutions for combating non-communicable diseases. And of course, the chairman and the chancellor of the university, whom you have met. So when we talk about the third SDG of, keep moving, and now the burden of non-communicable diseases and where physical inactivity is a major risk factor, another aspect here that we'd like to bring to everybody's notice that the Technology Vision India 2035, which is now recognizing the need for reforms in technology, very clearly based on all the evidence says that India is galloping in certain areas of technology, like the mobile. It's cantering still in aviation, trotting in some areas, but when it comes to healthcare technology, we are barely walking. And that was something. Now this document came in 2035, came in soon, around the same time that this center was established. And so this is one of the focus of the Center of Human Movement Science. The vision is to generate an integrated task force of healthcare professionals and engineers to be able to come together to design and have culturally palatable movement solutions for combating the burden of non-communicable diseases. And the four major, and along with this, design technology and validate technology, and therefore you see four more major domains of the center. It's research, it's training, it's patient care and technology design and validation. And all four are integrated because each one learns from another. And this is what are the activities that happen. So when we talk about movement, many institutes across the globe, whether they are health institutes or whether they are technology institutes, would typically have a gate laboratory. So when people come in here and come in and say specifically, is this a gate lab? We say that this is a human movement science lab because there is more to walking which can be explored, which needs to be explored so that it can be applied in the daily physical activity recommendations for people. Particularly because in a city like Mumbai, whatever that you have been traveling and all of us who are here, we always have reasons that there isn't enough space, there isn't safe space for physical activity outdoors, there isn't time. So when we have all these constraints of time and space, we're trying to have alternate forms of movement other than walking, swimming, and running, which can be then applied in daily routine for improving physical activity. So the trajectory of the journey began in 2015, where we first started with fundamental research. 9 months, that's one entire term, 3 trimesters, we had to spend on first generating the normative reference values for the Indian population, because the technology which came in here for evaluation came from US and from UK, and of course the softwares that came along with had the data reference values which were generated from the population over there. And therefore, there was a need because the Indian population is so different in terms of anthropometry. Movement is influenced by socio-cultural aspects as well, like we engage a lot into ground level activity, and which is why there was a need to do this. So we have over 2,000 consented healthy individuals from 5 years of age to 75, and that set the stepping stone then later on to analyze different movement forms to be able to then report. The major thrust areas here are aligned with the National Health Mission to reduce the burden of non-communicable diseases, echoing the need for rehabilitation, the WHO Rehabilitation 2030 call, and of course the theme of movement for health by World Physiotherapy. So as you saw there, those 5 fingers, one of them is yoga asana. Yoga has several components to it, but we are talking here in terms of the asanas, which are the poses of yoga. This is just one demonstration. So this is a sequence of 12 poses of Surya Namaskar. The yoga asanas, which are a sequence of 12 poses, and this is a greeting to the sun god. This was a part of our culture. This was something that everybody related to at the beginning of the day when you prayed at sunrise to sun god. And this is how we're trying to see how our Indian knowledge system can be revived again with evidence through robust science to be able to then integrate that into physical activity solutions that can be offered for reducing the burden of non-communicable diseases. So all the research that's going in gets not only published in scientific papers, but also goes out to lay people because otherwise it remains accessible only to the scientific fraternity. So there are efforts that are made in. And these are a few yoga-related projects which are going on in various conditions like back pain, in patients with chronic obstructive pulmonary disease, in children with cerebral palsy, and in patients with stroke. Because when we talk about exploration of movement in all these conditions, whether it's the movement of the thoracic cage in a patient with COPD, or whether it's the movement and postural control of a patient with stroke, or whether it is a movement of a patient with the spinal movement of a patient with back pain, we need evidence before we can say that yoga works, and how does it work, and what would be the dosimetry, when is it that we do not recommend which asana, and that's the science that's trying to be generated. There are several extramurally funded projects. Another major area is traditional dance forms. all of us who are into movement-related science will appreciate there is huge volume of research available on ballet. There are several papers that talk about one interphalangeal joint in ballet, different poses. This is a land, India is a land of rich heritage of dance forms. We have from the symmetrical dance forms of Bharatanatyam to the asymmetrical Kuchipudi to the spins of Kathak, and there are many more. So this is a modest area that is begun that we have, and now we have one PhD scholar, Dr. Akila Natesan, with whom you will interact. She's a Bharatanatyam dancer herself, and that's something that she's taken on after the first few fundamental research papers which have been published. There is part of the work happening with University of Sydney, which tends to be absolutely focused with areas of ballet. So that's the vestibular function in Kathak dancers, because when you talk about Kathak, it is stimulating the vestibular system. What happens is, the reason why this is here today on the platform of rehabilitation conference is that when we have patients who come in and mothers who come in with cerebral palsy children for gait analysis, for therapy, they say that after a certain period of time, children get bored. I mean, how much are they going to endure that same form of exercise? So if we can build dance into therapy, if we can build different alternate forms, and of course the beauty and the essence of dance is that it's not only movement, but it is rhythm, it is music, it brings in eye-hand coordination along with the body movements, and it has those positive effects that come in onto the system. So while we talk, just go back. So while we talk here, back, yeah. So Kathak is one dance form, Bharatanatyam is another dance form that we've begun exploring. There are few papers which are already available out there in PubMed. Down syndrome is another condition, and Parkinson's is yet another condition which is being explored. Wherever there is application of movement therapy, alternate aspect, and one of them is dance form. As we move on to the traditional sports, because when this center was established, this is Kabaddi, that's Kho-Kho, that's Kho-Kho again, this is Kabaddi. Gymnastics does not need introduction. Today we had to move the table tennis table out from here, because then we have the table here, we have a dental chair here sitting in to have dental postures, because we will give you a demonstration and a tour of the lab to be able to show you the facilities. But what we at it is that we said in 2015 that there is a lot of research happening when it comes to football, when it comes to the most glamorous sports which are out there on the international board. But when it comes to the traditional sports which are still played in India and slowly now coming on to the international board, like Kabaddi, like Kho-Kho, we need to explore the science of these sports to be able to then train our sportsmen for better performance, understanding the risk profile, and then rehabilitation for return back to sport. So that's what happens, and these are few of the papers. What you saw in between is skipping, particularly, now when we say skipping, I mean, do we know how much? Do we know what kind of footwear helps best? How much of what is the dosimetry? So these are the specific questions that the research intends to answer so that we can have an evidence-based package that goes out to people who don't have time, who don't have the space to be able to run, to be able to walk, don't have access to a swimming pool. So these are simple occasions like that. What you see at the bottom there is a jump, and this side on your right is, yeah, just play that one at the bottom, the Khalsa. Okay. And of course, along with that, there is badminton, and there are those raids of kabaddi, the scorpion raid, be it because kabaddi is now picking up huge way. It's up there in the north, it's coming up in Maharashtra, and these are the sports which are being explored. Something that all of us did a few years ago, I don't know how many of you all still do it, but sit on the floor and then get up. Okay. This is what we probably did for every meal. We did that for every ceremonial function. We just sat in different forms. We probably sat in this pose for a namaz, or we sat in this pose for a prayer, or we sat in the church here. But now we've come to 90 degrees of hip and knee, and that's where we have lost the motion of the hip. Particularly, the knee still comes in with some of the other activities, but particularly the hip. I was really surprised in my 8 years of stay in the UK, working at NHS with different patients, as to see that every third or fourth patient in the musculoskeletal ward would be a person with hip replacement following osteoarthritis. And it always made me think, why in India we don't see so much? You know, we see knee osteoarthritis, but not so much of hip osteoarthritis. But it won't be a surprise if that comes in another few decades here as well. And that's, I'm not saying we're not trying to establish a cause-effect relationship here, but just the way the lifestyle is changing, the activity profile is changing, and that's where we thought that it was essential to go back and explore squat particularly. Particularly squat, and that was the research of Professor Bela Agarwal. So Bela's research was on squat, and she will talk a little more as we go around to tour. And what she tried to do was evaluate and explore squat biomechanically, structurally through MRI scans, and biochemically through biomarkers. So that was an integrated approach to exploration of what's happening at the knee joint to be able to. And this is something that's still in a lot of the community which works, whether it's the fishermen who sit down, whether the gardeners who are out there in the field, whether it's the farmers who are there out in the farms, adopt still this as a posture. Also, what was missing was when we referred to the neurodevelopment chart, we did not have squat there. So we know when the child holds, when the infant holds the head, we know the developmental profile, the developmental milestones. I can see heads nodding, but when does a child come up from a squat or go down into a squat posture? So we followed up longitudinally for 18 months, babies, in order to try and identify that. This is all out there. And also had that as one of the applications. So all this research evidence is synthesized to respond to the non-communicable diseases. A movement for health is what we're trying to generate here. And DREAM is an approach that we are testing, that is detection, rehabilitation, and monitoring. It fits very much into what we have been saying since morning, that if we have early detection of the impairment, rehabilitation, and then monitoring, because what happens very often is we stop at rehabilitation, whereas there are some conditions which need monitoring over a period of time. So these are the different disciplines that come together here for the research projects, and that's across lifespan, that there are several projects across the different body systems. About the temporomandibular joint. Oral cancer is a big thing in India, and this is an application happening in women's health. Encouraging ground level activities even as a childbirthing posture. Those are different neuromotor conditions, because even in most therapy clinics, we would stop at walking training. We need to go back to training of the ground level activities as well. So these are just some glimpses of how it gets integrated outside the lab. And now, particularly in women's health, squat would have been a posture for childbirth a few decades ago. Because when we interviewed some of the old mothers who are now in their 60s and 70s, particularly from the rural settings, said, yes, we did deliver. And for them, this wasn't a surprise. They were like, yes, we did that. Currently, it is the horizontal posture, obviously for several reasons, for safety and all of that. But revisiting this posture to be able to then bring it into a safe environment and change that space of the labor room with an opportunity that the pregnant woman has to choose the posture that she'd like to deliver in. Because when we had the mothers come in, they said that until we come into the hospital, because in India now, deliveries are institutionalized, the ASHA workers are incentivized to bring in the pregnant woman into an institution for the delivery. So the best part is that the mother is doing all the ground level activities, whether it's cooking, washing clothes, washing vessels, and then suddenly she comes into an institution for childbirth. And there, that same posture which would have helped her so much more with mechanical efficiency is taken away, and she is attempting to deliver in a horizontal position. Now, this is where there is a lot of deliberation happening. We have a birthing table, a birthing chair, which is customized so that we have an opportunity for the birth attendants to monitor the neonate, to be able to do the procedures that they need safely, and yet allows the mother the mechanical advantage to be able to be in a partial squat posture to deliver, particularly in the second stage of labor. So that's something that was funded initially by Indo-Canadian Shastri Foundation, and it's an ongoing research point, and we have great positive feedback from the mothers. Of course, we'll talk about details of all of this. Another project that's happening is Bal Vikas and Bal Swasthya, and that's through the 1,000 days in terms of monitoring the children, and this is supported by Rajiv Gandhi Science and Technology Commission, which I mentioned earlier. So we have computer science engineers who are here with us at the center, and they work together to be able to empower the mothers and the caretakers along with the grassroots healthcare workers. The pilot testing of the project is on, and we will be very happy to release this very soon after we finish the first 1,000 screenings. We have finished 700 odd, so we are still short of a few more numbers, and once that's over, that's when. And then the whole idea is to integrate that into the other apps, mobile-based apps, which are already out there, like the Poshan Abhiyan, the Matrutva Suraksha Abhiyan apps, because the Maharashtra Knowledge Network group is helping us to be able to communicate with all these divisions and see how then can be a single app for the mother instead of she having to tap on several apps for several things. Now this is about a spring-loaded passive exoskeleton for the Mathadi workers. You may have seen a few pictures. Mathadi, for those who are not aware, are people who carry weights on the head. And these are the laborers who are doing this day in and out for 8 hours per day, 6 days a week. They cannot take a day off, because if they take a day off, they lose their wages for that day. We have very close to this place, about 4 kilometers from here, a Mathadi hospital that does have facilities. And these are the people who are afraid of any mechanization in their workspaces, because if that happens, they fear that they may lose jobs. So finding some clever solution so that they are able to function without irreversible damage to the spine, and they are able to continue and, most important, detect if there is any red flag out there. So that's an activity that's happening. The terms of spine pain, osteoarthritis, we've mentioned before, so I'm not going to move on with this. In diabetes mellitus, diabetic neuropathy is a huge, huge area. So we're working with the engineers to be able to detect the stiffness of the plantar tissue as one single measure of risk for ulceration. India is a huge capital of diabetes, and so this is a device which is patented, designed in collaboration with IIT Bombay, and now the field testing is on. We've covered close to 1,500 people, but we are waiting still because the variable itself of plantar tissue stiffness is new to clinical algorithm of existing variables of pressure and sensation. Powered transtibial prosthesis is something that is a fascination of many sitting around here, and particularly for these reasons, that we need technology, we need assistive technology that is culture appropriate. We have the most advanced state-of-art companies here now in India, which are providing their products, which are excellent, but do these products meet the needs of our cultural practices? And if not, and there are some which do, there is another generation which is coming up which do, but can our people afford that? Do they have any insurance which covers this? So that's where there is a need for this kind. So this is again a project with IIT Bombay, which is submitted, and then further on, another one that's going on is osteoporosis. Because fracture of the neck of the femur is a very common story in the elderly people. And that fracture changes the life of the elderly. So how do we actually do this in the routine clinical setting? Because otherwise people have to take bone mineral density scan, which is available only at few tertiary care hospitals, even in the metros. So how do we get to that point? So this research is supported by Department of Biotechnology, and that's something that's going on, and we call that Swasthya Astitva. Since morning we have talked a lot about this major challenge that India is facing and the world is facing. And Poonam Desai is one of our PhD scholars who's submitted her thesis, and Poonam will be very passionate to talk to you about what is it in terms of comprehensive geriatric assessment of the elderly people in India, because we did not know where to stand, where to start off. My own experience of sitting in the outpatient clinic of NHS, whenever there was a patient, was an Indian patient who came in, and the therapist who was sitting there would measure the hand grip strength and say that this is not there. But we did not have the evidence to say that it can never be there. There are different performance sets with respect to what is the anthropometry of the hand structure and how is that been constitutionally, the body make, the muscle mass and all of that. So there's a need to have comprehensive geriatric assessment, which is what Poonam has done, and also tested an outdoor exercise program to be able to integrate and make that far more. Alongside, Poonam is also working on this project, which is funded by the Department of Science and Technology, to develop a mobile-based technology app for the elderly people within the community, so that we can guide them to some extent without they having to wait for either their son, daughter, or a neighbor or somebody to bring them to a setup where therapy would begin, where assessment would begin. So this is still happening, and this is in the making. Alongside, there is an integrated geriatric training program which has been designed, which is supported by the Department of Health Research, because in order to address the 5 major geriatric giants, otherwise typically an elderly person would land up going to the general practitioner for something, and then to somebody else for dementia, or memory, cognitive problems, somebody else for urinary incontinence. And so this was something that was felt as a need, and that's a training activity. So that sums up the work in the 4 domains of research. Those are just pictures of certain programs that happens of clinicians and engineers. So we have around side tables. Only thing is that at that time when we have tables, they're not decorated and it does not look as ceremonial as it looks like this. But it's interesting to see the interaction and the dialogue that happens between the engineers and the health professionals, because each one of them is complementing the another in order to understand what is the need for movement-related solutions. So we have several of those that happen in terms of gait analysis, posture, balance, and various aspects of movement. So these are just a few glimpses from there. During COVID, all this was happening online, but now it's come back again. And the model that we follow is 1 health professional masters and 1 engineering masters. So we have typically either an MTech or an MPT or even an MS project that's happening, which is designed by the 2 supervisors, and that allows us to use the seed money intramurally of the 2 institutes to execute that project. But of course, that is something that happens very slowly, because each time a student finishes a project, then there is a pause in that research activity, and hence the need for funding for more such. So that's in a nutshell. Those are the different conditions that can offer, and we have constantly feedback from clinicians and people from these domains to be able to say what is relevant out there that needs to be researched here. Because we do not want to take an approach of first researching and then finding the evidence, but rather understand the need out there in the villages, in the tribal areas, which MGM Institute of Health Sciences has adopted as a part of Unnat Bharat Abhiyan, and then to be able to address those needs here, to take them back as translational work. In terms of technology design, so far there have been a few technologies that have come in, have been designed as well as validated, whether it is the elderly population, the neonates, training devices after COVID that were felt for respiratory disorders, the hand grip measurement devices, the sweat biomarkers, a non-invasive biomarker testing kit, foot muscle strength. These are just a few ones which are in there, and it's the validation that's going on with prosthetics within film. Because as I said, we do have some of these available, but they are not affordable. And we do not want to settle or compromise on the low-cost technology, but we'd rather have appropriate, robust technology which is affordable. So this is a list of the devices. Some of them have gone ahead and won the BIRAC awards after their validation, because the validation does help. And that's the summary of the output so far. With 2 years of online work, the spins have now started, the wheels have started spinning now of funding, which initially was a huge challenge. But we always said that it's only a means to research development, that's not the end. So with huge support from MGM Institute of Health Sciences and now from the Department of Health Research, Department of Biotechnology, Department of Science and Technology, and Rajiv Gandhi Science and Technology Commission, we've been able to move ahead. And the basic biomechanics of musculoskeletal book, authored by our very own beloved Professor Margarita Norden and Dr. Viktor Frankl, has the last chapter which talks about biomechanics of indigenous postures, because so far we only spoke about biomechanics of walk or run, or most of the activities which were a part of the lifestyle away from where the research labs were. And all this work happens with collaborations within the country, between health institutes, engineering institutes, as well as outside the country. And a few of them are out here on both the maps. So engineering institutes like IIT Bombay, BETIC centers, Madras, IIT Madras, SVyasa, the Yoga Institute in Bangalore, because Dr. Nagendra Guruji said we have everything else except biomechanics. So that's where we have those complementary associations to be able to move in. These are just some of the glimpses. As Dr. Ashil was saying, one of this picture will go in here for the next presentation. So we are very, very honored to have each one of you here today at the center. Please feel free to suggest, to give your feedback, criticize the work, and if there are any projects that you would want to be associated with the center that we could work together on for this common goal of finding alternate and many more physical activity options which can be offered to the patients with evidence, so that we know that we have been doing enough for people to say that no, I don't have the space to walk or run, or I don't have an access to the swimming pool. In the last 9 years, it's now ready to emerge as the National Center of Excellence for Human Movement Science. And in the next few years, we are looking forward to this becoming a Southeast Asia regional center for technology validation. So far, the technology design and validation in the country is happening, but we have been talking about expanding it to the neighboring areas. And of course, our inspiration is from none other than Madame Curie. She could actually research and apply that in her lifetime. This is only a modest effort. These are all the masters, scholars, the interns who work on their research projects within the School of Physiotherapy, Prosthetics, Orthotics, Department of Orthopedics, Respiratory Medicine, and the various other disciplines that we've mentioned. And that comes to the beginning of association with each one of you. As I mentioned, if there are any projects, there are any ideas that you would want to use this facility for, you're most welcome to come and join hands. Thank you very much. So what we will now do is, I know we've been sitting and it's time for a cup of tea, coffee, so we will serve tea and coffee inside here. And feel free to move around to actually see the facility. The lab, many of them have come and asked, why is the wall still bare? I mean, this does not look like a fancy ceiling, because we are very tempted to cover up everything and, make it look very flushed. The reason why these cameras are still high up there is because right from the dance posture, you need a complete capture volume to the bowling, to a badminton smash, and which is why you will see, if you see those red pipes are the firefighting pipes, and we could not cover them for this simple reason. So feel free to walk around. If you have any questions, all of our teammates, and I'd like to introduce all of them. Professor Bela Agarwal was the first PhD scholar of the Center of Human Movement Science. You've seen her. Dr. Triveni Shetty completed her project in cerebral palsy evaluation, multiple level. She's an associate professor and she takes on now the cerebral palsy related research. Poonam Desai is the lady I said, she just submitted her thesis in geriatric care and she was awarded the Women Scientist Fellowship by DST for her work. Akhila Natesan is a Bharatanatyam dancer and very passionate about dance biomechanics. And Akhila is working on now bringing in the dancers here particularly, because dancers otherwise like to believe that all that they do is perfect and that there's no need for anything more. Victoria Kuttan is working with the dentists to be able to understand the postures that they get into for different procedures and the temporomandibular joint related work. Saili Zadhav has joined us very recently, and Saili will soon begin her work in one of these areas. So this is the core team which gets supplemented by the various researchers across in the university. And over to you now for any. So this is a team which makes the center.
3 cheers for women power.
How is color coding decided? Color code is indicated.
Yes, so basically you see the 3D pattern on left hand side. So green is right and red is left. And this is a universal color coding that is from the system. All over the world, whenever there is a 3D motion analysis system, this is the color that is being used. So that's left side and the red is left side and the torso is blue. Now the graph colors can be changed. The graph also index blue is right and the red is left. So basic position is that's it. It is waiting to happen. So what happens is the normative reference values. So we didn't have graphs for Indian population because when we have been in anthropometrically we are different compared to the Western population. So first we came to the normative reference values. So just open a polygon report. So what we do is if we are having a patient and we are analyzing the walk movement, we superimpose their graph on the normative reference value. So we know what is the deviation. Also we assess the consultants who are the referring physicians to what exactly is the deviation and what is the inference and interpretation and what are they supposed to work on. Like there are certain critical instances during gait analysis that are there that we help them to understand how these are the movements, probably especially pre-post surgery or pre-post rehabilitation. Also sports people come for their performance enhancement. What is the skill? What is the biomechanics of their skill? Understand if they are like indigenous skills. In Kabaddi we didn't have any data to have some reference. So what is the national level and international level? When you have that reference, then the amateur based thing like so you are as much from the
So how do you measure
we had a marathon running for 21 more kilometers and 44 was green here. His own performance was just
so this went into my PhD now, and now I have planned a protocol for dancers to train them and planning for the ones who are...
It's the normative reference value that's been generated at the center. And the blue and the red are the patient data, so for right and left. And what it does is it gives us information about what's happening in the sagittal, so flexion, extension, rotation and abduction, all three plane of movement. And why is that accurate? Because the camera frame is 1 second, it gives us 100 frames. So it's point, but yeah, that's how it indicates of the analysis.
So it's very interesting. It is a lot of people should know this.
We have our Delta system as well.
The ones who are going to snowball
the cameras talk about the movement that is happening. The forces is for the forces that are bringing about movement. So what are the structures that are making the movement
for my study, we had studied
the pressure? So if there's any camera, no, this camera is only, so if there's anything that it should be analyzed, it's only within the volume area. Right now, we usually don't allow people to sit here, but because this was a huge crowd coming, so we made the chair arrangement. Otherwise, it's like you can walk around, because this is the capture volume. So whatever's running, so we utilize the entire length of the lab for running.
It's a complete
the angular displacement. So we add a few markers so that the faster movement, like in skipping and all, we have to add because they are very fast movements. 100 frames per second was not enough, so we added markers. Yes, so maximum is around 400 frames per second. But what happens is because the video cameras are VGA cameras, so they don't then get synced. So I have to take video separately, but they can. Yeah, based on the there is a lot of discussion that goes around what is the market what we started doing, then we create a market